Uh, the disease is very aggressive, and it's not that uncommon in our area. In general, glaucoma is a progressive optic neuropathy that leads to changes in the optic nerve head, resulting in visual field loss. If not treated, will end it with blindness, unfortunately. And the glaucoma is divided into two major categories, the open angle and closed angle glaucoma, with each one of them has its subsidiaries or divisions. But we know the angle closure is not as in West, the incidence and so on about there, or its prevalence, about 10% of the whole glaucoma. Here, the picture, especially in the eastern half of the sphere, is totally different. So what I'm going to talk about, the introduction, we'll touch the introduction, the pathophysiology, which is the most important part of our topic today, epidemiology, classification, types, risk factors, clinical features of the disease, and management. So primary angle closure glaucoma, which is most of the talk is about the primary angle closure glaucoma in this setting. It's a common form of a glaucoma in Asia caused by iris bowing anteriorly to cover the trabecular meshwork. This, we call it a relative pupillary block, as you will see later. If this occurred complete pupillary block or in a rapid way, this will lead to or will cause an acute elevation or a prompt elevation of the intraocular pressure within a matter of hours, and causing or resulting in what we know as the acute primary angle closure glaucoma, which is the most destructive type of angle closure glaucoma. If not treated appropriately and in time manner, this can lead to really a severe visual impairment and even blindness. So if this occurred in a relative way, as you will see later, incomplete, this can cause intermittent pressure elevation and giving what we call it intermittent angle closure glaucoma that can pass unnoticed by the patient, or sometimes they feel or complain of mild symptoms like blurry vision, headache, brow aches, and so on. And with subsequent attacks of this type of intermittent, or even sometimes without these intermittent attacks or symptoms, can lead to chronic angle or can go to chronic angle closure glaucoma. So in the main types of angle closure glaucoma are the acute, intermittent, and the chronic type. In our area here, I was talking with Dr. Jadaan, we look to the pattern or the profile of glaucoma in our area that hasn't been touched as far as we know, and we look to the new cases that coming to the glaucoma consultant clinic, one clinic over 3 years, and we look to 1,236 patients during that time, about 2,300 eyes, and we found that 46.6% are the patient are of primary angle closure type, primary angle closure glaucoma type, and about 17% either primary glaucoma suspect or primary glaucoma, primary closed angle suspect or primary closed angle. So the total is about more than 60%. This is exactly a reverse of what's happening in the West. As I said, in the West, it's about 10% the prevalence of the disease. So it is quite common. So we concluded that the disease or angle closure glaucoma is the most prominent type of glaucoma forms in our area. Again, it's not as in China and Far East of Asia, but definitely differ from what's going on in East or West part of the sphere. So what is the pathophysiology of this disease? It's very important. Probably I will spend most of the talk about this issue if we understand the mechanism of or pathophysiology of this disease. It makes our life more easier. So it's a contact occurs between the iris and the anterior lens surface, leading to trapment of the aqueous humor in the posterior chamber. This will lead to elevation or loss of equality between the pressure of the anterior chamber and posterior chamber, causing anterior bowing or increased convexity, anterior convexity of the iris against the trabecular meshwork in a form we call it a relative pupillary block. So what is the concept of relative pupillary block? It's a resistance to outflow of the aqueous from posterior chamber. I think I have a picture. Well, so it is normally the aqueous formed in the ciliary body here, or produced by ciliary body, circulated the posterior chamber, giving nutrition to the lens, and then passes through the pupil to the anterior chamber to the main channels or main drainage system, which is trabecular meshwork. In a presetted eyes for angular closure glaucoma that we'll see their characteristics later on, the relationship between the iris, back of the iris, and the lens is very close. And this is anatomically setted. So with age, for example, 40, 50, or even before that, this proximity increases. And in certain positions, the iris, when it gets dilated, either physiological or due to pharmacological agents, the most contact occurs in mid-dilated position. So this will lead to entrapment of the aqueous humor in the posterior chamber. This pressure gradient, or difference in the pressure gradient between anterior chamber and the posterior chamber, will push the laxity or the lax part of the iris peripherally against the angle, causing Bombay or closing the angle, and then initiating the process of angular closure. So it is worse in hyperopic eyes. So what are the factors that influencing relative pupillary block? Pupil size, as we said, the mid-dilated position, 6-7 millimeter pupil size. This is the pupil size that lead or associated with more contact with the lens surface, anterior lens surface. The lens size, there is again lens size and position. In these eyes, usually either the position or the size of the lens is a little bit abnormally to the size or the axial length of the lens. Again, aqueous humor, when it gets entrapped in the posterior chamber, act as a force acting on the posterior surface of the iris against the angle, so increasing the convexity of the iris. And there is a role for aqueous suppressant in the treatment, as you will see later. And the rigidity or tension of the iris, again, play a major role as a factor influencing the relative pupillary block. So in the pupil, as we mentioned, the maximum contact in a mid-dilated pupil, this will lead to initiation of angular closure by either physiological, as we mentioned, such as dim light, emotional disturbances, shock, illness, or stress, or even by pharmacological agents that we use it for common cold, sedatives, muscle relaxant, or even dilating drops that we use it to dilate the pupil and to look for the fundus and so on. So these are putting the position, the iris in a position in a position that mid-dilated pupil. You say, okay, somebody may say, okay, why the angle when when you put this dilating drop patient doesn't have an attack of acute angular cardiac glaucoma? Why it occurs sometimes 2 or 3 hours later on? When you put the dilating drops, the pupil dilate fast. So there is no time to pressure to build and to really to push the iris against the angle. So it passes without any significant change in the intraocular pressure. But when you finish examining the patient and he goes home, and in 2 or 3 hours, when the pupils start to come back slowly, it's not fast, here it happens, the elevation of the pressure, and patient comes with acute angular cardiac glaucoma, and we have seen some cases presenting in this situation. So this is very important. So pupil size, as we mentioned, is very important, position of the angle of the lens and size. Aqueous humor forcing the, when there is a relative pupillary block and accumulation of the aqueous pushing the iris against the angle, here, this will increase the closure of the angle by the anterior bowing of the iris anteriorly. So, rule of aqueous humor, when we have a patient with angular closure, what the action of aqueous humor suppressants in this situation? When you give, let me see I think, when you give the, when you give the, so for example, this is an relative pupillary block or whatever, there is a pupillary block here. Come on, where is it? So when there is a block over here at the mid-dilated pupil, as we said, that the aqueous will be entrapped in the posterior chamber and pushing the iris against the angle due to the pressure gradient between the posterior and anterior chamber. So the aqueous humor suppressants, what they do, they decrease the volume of aqueous humor here. And also, the pressure will be decreased. So the convexity will be less, opening the angle. In combination with the role of pilocarpine as a treatment here, the pilocarpine will stretch the pupil, the iris away from the angle, and by contraction of the sphincter pupil, it will elevate or lift up the pupil from the lens. So this will open the path for the aqueous humor to pass through its normal channels and abort the disease or break the attack. This is the whole conception of the aqueous suppressants and pilocarpine. So pilocarpine will increase rigidity and tension of the iris. So even with the pilocarpine, when the iris is stretched, the aqueous humor will not be able to push the iris anteriorly as if there is no action of pilocarpine. You can ask if you didn't understand this point. So pilocarpine and aqueous humor play a major role in breaking the attacks during the attack of angular closure glaucoma. So aqueous humor, by decreasing the pressure and the volume of aqueous humor in the posterior chamber, decreasing the anterior convexity, and the pilocarpine by tensioning or stretching the iris, pulling it away from the angle, as well as making it as a board, so the aqueous humor will not be able to push the iris against the angle. So the pilocarpine reduces relative pupillary block by meiosis and decreased iris lens apposition, as we mentioned, and prevent the attack by pulling iris away from the topical meshwork and tauting or stretching the iris so that the iris or the aqueous cannot push the iris anteriorly against the angle. So these are the mechanisms of these two medications in angle closure glaucoma. So the pilocarpine used to constrict the pupil and increases aqueous outflow through the major outflow pathway. And also, pilocarpine, with this action, we know the pilocarpine lead to contraction of ciliary muscle. And when the ciliary muscle contract, what will happen? The venules will relax, isn't it? So then this will lead to increase the axial length of the lens. So will be more in a more position, in a more close position to the iris, as well as relaxing of the venules will mobilize the lens a little bit. It's a relative thing. So it will push the iris lens diaphragm anteriorly. So this may aggravate or precipitate an acute angular closure glaucoma. But this usually occurs with strong concentrations. 3%, 4% or so, this can lead. I haven't seen, to be honest with you, a patient, an eye precipitated by pilocarpine to an acute angular closure glaucoma, except in spherophakia, the patient usually comes with a shallow chamber, peripherally and centrally. And when you give pilocarpine to pull the iris away from the angle, this will increase the shallowness of the anterior chamber. So when you give sacroplegic, you will see the chamber depth is improved, and the situation looks like better than leaving it without sacroplegia. So yes, high concentration of myotics or cholinergic agents can increase or can precipitate to an acute angular choroidal glaucoma. So you can say, ask me, why we don't use sacroplegia in patients with acute angular choroidal glaucoma to relieve the block or pupillary block? Yes, if I'm sure that the sacroplegic agents will get the pupil to 9 or 10 millimeters, probably yes, I will say this is a good idea, but unlikely to get the pupil, especially in such a situation, to that size. So we use pilocarpine worldwide that to constrict the pupil to prepare the eye for the definite treatment of angular choroidal glaucoma by peripheral iodotomy, laser peripheral iodotomy, and it's better and easier, especially in our population with thick irises, to do a peripheral iodotomy and a stretched pupil rather than a very lax pupil and crowded pupil at the angle. So this is very important, but we need to keep in mind that high concentration can precipitate an acute angular choroidal glaucoma, but it's seldom. Seldom, okay. So the whole thing now, pupillary block or relative pupillary block, is responsible, and you need to remember this, for more or 90 or more than 90 of all angular choroidal glaucoma. This is the anterior segment OCT showing what's happening in a patient with an abrasiated eyes for this disease. You see that the mid-date pupil contact between the pupillary area and the anterior surface of the lens, and iris is pushed anteriorly, as you see here. So when you give, as we said, that the aqueous humor suppressants, they will decrease the pressure here, will decrease the convexity. When you give the pilocarpine, will stretch the iris more centrally and make it a broad-like. So the effect of aqueous here will on the iris will be much less. So the relative pupillary block is the major issue in this disease, although the problem is more complex, but we need to remember that the relative pupillary block is responsible for more than 90% of angular closure glaucoma, and its different types: acute, subacute, or intermittent, and chronic. This is one of our patients, I think, and you see, this is according to von Herrick classification or estimation. This is very shallow anterior chamber, and here you see there is no angle can be seen here. There is anterior bowing of the iris, and probably sometimes difficult to see it in our patient with angular closure glaucoma because of the shallowness of the chamber. So, but if you look carefully, you will see that there is really, you cannot see the angle. When you do the same quadrant, same setting, pressure gonioscopy, pushing the aqueous humor behind the iris with the iris here, so you can open the angle and you can see up to the ciliary body. So this is simple. If you can catch a patient, here the patient probably has normal pressure, no healthy disc, and so on, or he might have some sort of pressure elevation. But if you can catch the patient with this stage, in this stage, and you did a simple procedure here, which is peripheral iodotomy, you are solving the problem forever, hopefully. So this is an opportunity for us, being the angular closure glaucoma is a prominent form of glaucoma in our area. I think if we go, as we'll see later, and do a good randomized screening and catching the patient before or with early stages of the disease, we can abort the disease and we can prevent the development of angular closure glaucoma. Epidemiology, of course, race is much more common in Asian, as we mentioned. It is responsible for more than 90% of bilateral blindness in China. China is a major, the angular closure glaucoma is a major health problem in China. So it is responsible for more than 90% of bilateral blindness in China, and the BI is less the eyes, Asian eyes responding less to the peripheral iodotomy. Hyperopia, of course, it is abrasiated eyes for this disease, being small eyes, shallow anterior chamber less than 2 millimeter, And with older age, you know, the lens is the only growing organ in the eye that continue growing with aging. So this will increase the size of the lens and make in such eyes the proximity with the pupil is more. So this will a factor that may precipitate an angular closure glaucoma with old age. And usually, most of the cases are above 50, although sometimes we see it in 30 or 40, but majority of cases above 60. More common in females, and I don't know, to be honest with you, probably Ibrahim or others, they know, but I have no idea why more common in females. Family history is a very, in the past they said angular closure glaucoma has no genetic origin for that, but studies, among them there are 2 publications for us with other colleagues in genetic nature, and there is, they discovered that there is genes responsible for this disease. For this reason, first-degree relatives of patients with angular closure are at higher risk. They said about 35% are more at higher risk than patients without a family history of the disease, and should be screened. Patient with angular closure glaucoma, you should tell him that your brothers, your sisters, your parents, your first relatives should be examined anywhere in the where are they living. They should be examined, and especially look for pressure elevation as well as to the disc and so on, and to gonioscopy, because some of them, they may check the pressure and find it normal, although there is intermittent angular closure and can miss the disease. So you need to advise them for their first-degree relatives to be examined where they are. So what are the eye characteristics for primary angular closure glaucoma? Is small axial length, as we said, hyperopic eye, cornea is slightly smaller, and thicker and anterior position of the lens. These are all the characteristics, that put the eye at risk for development of this disease. Shallow anterior chamber, and again, risk factors, age, as we said, above 60, female gender, Asian population, shallow anterior chamber depth, and shorter axial length, and thicker lens, as well as more anterior lens position and family history. So these are risk factors for development of angular closure glaucoma. What are the precipitating factors? Dim light, as we mentioned earlier, that situations that put the iris or the pupil in the mid-dilated pupil position. Dim light, emotional stress, as we said, mydriasis, intense, strong meiosis, as we mentioned. In these patients, if you give strong miotics, as we said, the action on the ciliary body by contracting the ciliary body, relaxing the venules, can move the lens anteriorly and precipitating the attack. So that is very interesting, This is the action of the pilocarpine in open angle glaucoma. Its action is different in open angle than in angular closure. In open angle, we need contraction of the ciliary body, that the longitudinal muscles which insert in the scale spur pull on the scale spur, so mobilize the trabecular beams. So this is increase the outflow facility in open angle glaucoma. While in angular closure glaucoma, it pull the iris away from the angle, inducing meiosis, making the iris rigid. So the action is different totally. But strong miotics, we need to remember that in susceptible eyes can induce or precipitate an acute angular closure glaucoma. What are the clinical features of primary angular closure glaucoma? Most are asymptomatic in early stage until they reach a later stage, similar to open angle glaucoma. And this is the chronic and intermittent, which are forming the majority of primary angular closure glaucoma. May have episodes of intermittent angular closure with its symptoms like headache, as I mentioned, a slight blurring of vision, and the patient feels that it's his exhaustion, so he go and sleep, and then the attack released by meiosis during sleep, and he didn't pay attention to what's going on in his eye. Family history of glaucoma is a very important issue, and use of topical or systemic diseases drugs for other diseases, such as common cold medications, such as antihistamine and sulfonamide, topiramate, others, and also the diabetic drops. So these can also put the patient at the or precipitate an attack. What are the types of ankylosing glaucoma? It's acute, 3 major types, subacute or intermittent, and chronic. So acute ankylosing glaucoma, acute primary ankylosing glaucoma is the most destructive disease. Is the most destructive disease. If not treated, diagnosed and treated in an appropriate way and time, can lead to blindness. So what are the symptoms of this disease? Eye pain, headache, blurred vision with colored halos around the light, nausea and vomiting. Most of the time, if the pressure is too high, the patient may present with nausea and vomiting may be associated with his complaints. Science is very important here. And it is simple to diagnose acute primary ankylosing glaucoma. It's very simple if you put in mind what are the conditions that might mimic this disease. So conjunctival injection, cloudy cornea, edematous cornea, mid-dilated non-reactive pupil, very high IOP, may reach 60, 70, even more than that, and iris bombay. Iris bombay, as I said earlier, in such eye with these characteristics, probably it's not easy to appreciate it. So you need a very careful exam, and especially if the cornea is not that edematous, you will see, as you see here, there is bowing, anterior bowing of the iris. So, and mid-dilated pupil, as you see, and sometimes you may see with acute elevation of the pressure, you may see changes in the sub-epithelial anterior or subcapsular epithelial opacities, causing or leading or forming what is called glaucoma plicon. This is an infarction of lens epithelium. Again, you may see this is probably most of the time associated with subacute ankylosing glaucoma. You will see spiring of the iris stromal fibers. Also, you may see later on after the attack, iris atrophy, as you see here. This is after trabeculectomy, surgical BI, but you can see these changes. So what are the differential diagnoses that can help us in reaching the diagnosis? We need to keep in mind secondary ankylosing glaucoma forms, such as phacomorphic glaucoma. We need to pay attention to that. Phacomorphic glaucoma, yes, it exactly represent or present to the emergency room similar to the acute ankylosing glaucoma with high pressure, mid-dilated pupil, shallow chamber, corneal edema, all these things, and even nausea and vomiting. But when you examine the patient, you will see that there is another pathology. There is a lens, intermittent lens, or cataract in the eye. So this is a very important finding. And when you look to the other eye, you may find it either immetrope or normal, or even sometimes you find it a narrow angle. So this is very important and easy to differentiate between both conditions. Aqueous misdirection, very extremely important. Aqueous misdirection can happen after surgery, any surgery, even has been reported to be occur after YAG-BI. I'm not sure about that, but has been reported. So aqueous misdirection, we will find that the shallowness of the chamber is uniform, and the pressure is not high as in acute primary ankylosing glaucoma. So ciliary body swelling, post-peripheral retinal photocoagulation. And this I have seen more than one case. If the retina surgeon gives the BRP, full BRP in one sitting, this will lead to edema of the ciliary body and anterior rotation of the ciliary muscle processes, and leading to a secondary ankylosing glaucoma, but in this case, without pupillary block. And so the management is totally different. This is very important as the treatment of aqueous misdirection. The treatment is 180 degrees different from primary ankylosing glaucoma. There, you need to give cycloplegia and so on. Here, you need to avoid cycloplegia and give myotics and so on. So, or even after sclerobuccal tumors and so on. Other things like plateau iris syndrome, another form of ankylosing glaucoma, but people divide it or subdivide it into secondary ankylosing glaucoma due to abnormal position of the ciliary body and so on. Probably we'll touch it in another session. Non-ophthalmos, again, most of these people are prone to ankylosing glaucoma. So you need to look to these things to put it in mind so you can differentiate between a pure primary, acute primary ankylosing glaucoma and other conditions that might mimic the ankylosing glaucoma. So what is the treatment? Treatment of acute ankylosing glaucoma. It is a real ocular emergency. Real ocular emergency. As I said, if you not treated, diagnosed and treated properly, this will lead to a significant visual loss, if not all the vision. So medication, we start with topical medication, like aqueous suppressant, for example, beta blockers. You need to make sure that the patient has no contraindication for this medication. Cholinergic agents, pilocarpine, and adrenergic agonists, such as alphagan. And topical corticosteroids, very important. The eye is inflamed, and you need something to decrease the inflammation. Sometimes with acute ankylosing glaucoma, you may see a pseudohypopyon due to the severe ischemia of the iris that lead to pouring of the protein. And I haven't seen it, to be honest with you, but has been reported. So you need to give a very hit the eye with frequently with topical steroid, not less than 40, trying to decrease the inflammation and prepare the eye for the next step for your intervention. Systemic, again, systemic medication is very important. Intravenous carbonic anhydrase inhibitors such as Diamox, as well as mannitol if there's no contraindication for these medications. Then the radical treatment, laser, whether laser iridotomy or even surgical iridotomy. So this is very important. Timing is very important. You don't need to go and take the patient to the laser quickly. You need to quieten the eye, to break the attack, and then make the eye more quiet. And this situation will make or facilitate your peripheral iridotomy to make it more easier and more successful. If it is not possible, you can go for surgical BI. But I don't remember that I need to go for surgical BI in acute primary ankylosing glaucoma in my life. It happens in acute and uveitic patients, but in acute primary ankylosing glaucoma, never ever. Then once you give the medication, you break the acute attack, you did the BI, don't rush to admit the patient. This is one of the patients that need really admission. It's, as I said, it's a real ocular emergency. So once the eye, next day you can look to the patient, or even you can delay the eye until next day. You need the eye very quiet. So then check the pressure after BI, after medication, taper your medication, and see is there anything needed more than peripheral iridotomy and topical medication. And even most of the cases, if they are catched in appropriate time, they don't need more than peripheral iridotomy. So reevaluate by IOP and gonioscopy. And if this is, not enough, or it is long-standing disease, you may need to go for intervention, trabeculectomy. But again, don't take the patient with an angry eye. You need to make the eye very quiet to increase the chances of success of your procedure. Clear lens extraction. Again, nowadays there is a study reported a few years ago comparing the peripheral iridotomy, whether in acute or in subacute and chronic, comparing the effectivity, efficiency of peripheral iridotomy to clear lens extraction, and they concluded that the clear lens extraction is superior to the peripheral iridotomy, and you don't need more than that. Even if you remove the lens is a major contributor to this disease. So probably after that, you may need to go for 1 or 2 medications. So keep this in mind. Of course, don't forget the other eye. And I want to leave some time for discussion or for your questions. Don't forget the other eye, and prophylactic iridotomy is mandatory. And of course, you cannot suggest it to the patient during the acute attack. Once you optimize the affected eye, later on you can ask him to have a prophylactic iridotomy. Intermittent, subacute, yeah, symptoms from rapid, what the symptoms happening, and which is, we said, blurry vision, mild blurry vision, brow aches, something like this. This is from rapid angle closure and reopening of the angle. So this is sometimes neglected by the patient, usually resolved spontaneously during meiosis by sleeping, as you mentioned. And when you do a gonioscopy on this patient, you may find a peripheral synechiae, occludable angle, and this is very important, pigmentation. And it's very frequent that, especially inferiorly, with subacute attacks, there is a release of pigments from the iris and deposited inferiorly all in the Schwab's line. Many of colleagues, they consider or they think this is a trabecular Schwab. It is a deposition of pigments due to the subsequent attacks of the intermittent attacks of angular closure glaucoma, and mistaken for an open angle. Although this is a good sign that this is really a patient who developed attacks of subacute attack or intermittent attack of angular closure. Treatment again, YAG-BI is very simple and can resolve the whole issue. Or if the patient is above 50 years and there is no much left from accommodation that you will lose it, you may go for phaco and PCIOL. It's very important. Chronic angular closure glaucoma. This is very important. We said it may follow acute attack with persistent peripheral synechiae, more commonly follow creeping angle closure, as seen in most of our population and Asian population, and most common cause for blindness in Asia. This is one of the most causes of blindness in Asia. And when you look to the gonioscopy, you will find the permanent peripheral synechiae, and the clinical course, it's similar. Patient has no symptoms, or he forgotten the symptoms that he developed years ago of subacute attack from blurry vision, headache, and so on. He forgotten about these minor symptoms and signs. So when you see the patient has a silent disease, it's a silent disease, behave exactly as primary open glaucoma, no symptoms, no signs, until the patient reaches a late stage when he's have significant visual field damage. So this is, and most of the time, because of this chronicity and asymptomatic, probably significant number mistaken as a primary open glaucoma. So you need to be careful in your examination, your gonioscopy. So angular closure glaucoma probably most of the time present or behave as primary open angle glaucoma. Treatment, of course, you can do peripheral iridotomy to say, okay, why I should do peripheral iridotomy as long the angle is mostly closed. Yes, you need to do peripheral iridotomy to prevent further closure. And even if you're gonna need to, or mostly you will need medication, or even if you need to go for surgery, unless the disease is advanced and you're going to do trabeculectomy. I skip this step of treatment. So lens extraction with IOL, as we mentioned, limbal surgery, trabeculectomy, for example, and you need to worry or to put the possibility in all angular closure glaucoma of possible development of malignant or aqueous misdirection. It is most commonly following glaucoma surgery, especially in angular closure glaucoma. So there are precautions that if you take it, you will minimize or reduce this possibility. I have, I think, yes, a lecture I give it in one of the international talks. They asked me to talk about what are the measures to minimize the complication of trabeculectomy. Of course, in this case, you need to take certain measures, either pre-op or intra-op or even post-op. Before surgery, you need to optimize the eye, as we said, to make the eye an optimal situation to have the surgery. Intraoperative, you need to take other precautions that whether conjunctival limbal or conjunctival periotomy, the screw flap, where to put it, up to what at the lumbus, where, and again, when you enter the eye, you need to decompress the eye. And at the end, I will not spend my time in this issue, but at the end, this is the most thing that you can look at it at the end, that you have to have a deep chamber, and you see there is no spontaneous aggression of aqueous. There is no blip unless you compress or do a massage, as you see here. This is where I'm a final step during surgery. So there is no blip here, but when I press near the flap, forming the blip, pressure is good, make sure there is no leak, and we know in this situation you avoid many of the complications that happen as early post-op complication after trabeculectomy, starting with shallow and flat chamber, which are possible initiate the cycle of aqueous misdirection, choroidals, retinal detachment, many things. So in this way, you are really doing your job, and if there is anything, you can intervene at this point, if there's a leak or so. So this is very important. So you can see your first post-op day, this is the same patient, has been operated before, as you see, all trabeculectomy, and next day, this is the situation, you see the chamber is nicely deep, and so this is what you need. Atropine is a mandatory after trabeculectomy, especially in angular closure glaucoma, although I know in West they don't, some of them they don't give atropine, some of them they give valocarbine, but I think it's a must in our population here. So in summary, yes, angular closure glaucoma is an aggressive and visually destructive disease, especially the acute type. Based on our available data, primary angular closure glaucoma is a major cause of visual impairment and the blindness in our area. And to minimize or reduce or even abort such a problem, screening programs directed to primary angular closure glaucoma is really and badly needed. I thank you for your attention. I will leave some time for questions. لا تقول لي يا عمر انك فاهم السبجكت وكده. اسال. ها؟ طيب. Questions? Acute, I don't think this is a good idea. I think acute you need to break that. Of course, IV is much better faster in acute attack. Because a chronic, I never, even the patient comes with 70, you are giving. If the patient comes even with 70 millimeter of mercury pressure, a chronic case, I never think about IV at all. Never. So he has been here with this pressure for, I will not say years, but months probably. But in acute, I prefer to give even mannitol, not only acetazolamide. So yes, I prefer to give mannitol, IV and aqueous suppressants, as well as dehydrating agents. Yes.
My question is regarding the anti-eye. Many patients come with treatment iris. Do you have any advice?
Yes, as we mentioned that in Asian, we are part of Asia, of course, and because of our irises, dark irises and thick irises, sometimes you need sometimes to put it on more one sitting. But definitely you need to prepare the patient, especially in acute cases, you need to quieten the eye to minimize the bleeding, to facilitate your perforation of the iris. You try to find a crypt and so on. But if you think it is difficult to get it in one sitting, you may divide it in more than one sitting. Yes, it is not an easy, but it's not that difficult in our population. So you need to evaluate your individualize the cases. If it is very thick and you think it will need more energy, and so you need to divide it, and you can complete it next day or the day after. Any? Well, parameters you can go. For example, I usually start with a small amount of energy, for example, 2 millijoules, and to decrease pigment liberation. So once I take the surface of the iris or stromal part and reach the fibers, I go for example, 5 or 7 even. But good focusing is very important. And yeah, you don't need to exceed, I mean, especially if the chamber is shallow, although YAG is all or none, it's not like argon that you may affect endothelium unless you focus on the endothelium. So I can go to 40, 50 millijoule or even sometimes more than that. But if you can evaluate, am I going to penetrate this iris or not? If not, I can leave it for another day. Yes? No questions? عشان ناخذ زيادة يعني talk about more. You have I try to make it this to give you time to ask questions. If not, Omar. Precautions, yeah, precautions, yes. Let me see if I can, if you don't, precautions, yes. How to avoid, yes, this is it. How to avoid complication after trabeculectomy. Let me just remember the lecture so I can just choose these slides. Okay, so as we said that the gold standard, this introduction and so on, so operative precautions, preoperative precautions, for example, here. Huh? So preoperative precautions, you see here, identify patient at risk, systemic conditions, systemic hypertension, anticoagulant, anesthesia, all of these to avoid, for why we said anticoagulant, if you are going to give the block, it may end it with retrobulbar hemorrhage or so. Surgeon selection, in such cases, for example, single-eyed patient with angle closure glaucoma or with any type of glaucoma, I prefer to do it, or the most experienced person to do it. So you don't need to give it a trainee. Again, the operative precautions, traction suture and tissue handling to avoid buttonholes in the conjunctiva, tears in the conjunctiva, hematoma to avoid, for example, scleral muscle traction suture. Nowadays we are going to, or we are using limbal or corneal traction suture, again to avoid ptosis also, and excessive cautery. Cautery will invite the inflammatory cells and will make the healing processes more aggressive. Selection of the quadrant. You need to, before you start, to check the mobility of the conjunctiva. Am I in a quadrant that it is good, or the mobility is good, so that I can utilize mitomycin C and close the conjunctiva without overtension? This is very important. For example, is it, I mean, probably it's a video, isn't it? No, this is picture, okay. So, very important to choose the quadrant. Then, yeah, this is traction suture and scleral flap, radial incision, posterior blip. This is what we are looking for, to minimize the leak. What we mean by posterior blip, I'll show you now. To minimize the leak, to dissecting and dissecting a blip in the cornea, as well as overhanging a blip. How do we do that? This is the, come on, this is supposed to be, video, but I don't know. This is what, it's not a problem. So you need to go a little bit, about half millimeter beyond the limbus. And when you reach there, you make it a tunnel-like. Press what? Where? Here? اه let me probably you need this one. عمر تعال يا اخي ابوك مزنوق ابوك مزنوق يا جدع. والله ما في. Okay, ما بشغل. Anyhow, so you need to go so you need to go a little bit less than or beyond the
صورة.
So it's okay, no problem. Beyond the or posterior to the limbus to avoid anterior blip. It's okay. Posterior to the blip. Okay. So careful use of anti-metabolites. So metabolites, you need to make sure that really the conjunctiva gonna be covering the area without tension. So you need to test. I think there is a picture also. Yeah. See, I'm trying to pull the conjunctiva to see is it covering the limbus or not without tension. If there is a shortage of the conjunctiva, probably it's much better to skip the antimetabolite. This is what we have said. So you need to go, not to go to reach the limbus, and they make a tunnel like mitomycin C. Mitomycin C also here, this is, to be honest with you, it's not a routine. I put an ointment, sterile ointment at the edges of the, especially in patients, very specific patients, to avoid the touch of the mitomycin C to the edges of the conjunctiva, so will not inhibit the healing process at the edge of the conjunctiva. Gradual decompression, this is very important. Gradual, in any case, whether the pressure is high or even in 20 or less, I usually decompress the eye before I perforate the eye and spend some time during which I push my scleral flaps, scleral sutures, suture and the scleral flap. And size of the topical opening, you don't need to put it very large, a small one, you don't need as in the bust. And as you see here, small ones. And again, whether to put the opening in the scleral part or the corneal part. There is a good study in the British Journal of Pharmacology that they showed the incidence of hyphema. In these cases, it's a prospective study. They found that if you put it in anterior, come on, this is a group A, number 30, 18% incidence. Management of remnant site of internal vestibular corneal and corneal scleral. Yes, let me see the. Okay, so group B, where yes, this is posterior. No, this is the posterior one. So they found that the hyphema was in 56% of them developed hyphema, while in group A, where the trabecular opening is anteriorly, 18% developed hyphema. So overfiltration, again, titrated scleral flap suture, this is the most important. Avoiding overfiltration is the key to prevent major early post-operative complications, shallow chamber, flat chamber, choroid detachment, hypotony, maculopathy, even aqueous misdirection, as you see here. So this is very important, the final step that you are doing. These are the complications that might happen. And operative meticulous, yes, conjunctival closure, protection of the wound, scraping of the limbus before I put the conjunctiva to make it a raw surface. So this will help or initiate the healing between the edge of the conjunctiva and the lumbar area. And tension, testing with fluorescein, of course, before you finish. Yes? Probably this is the video, the last video. No? So, yeah, this is the precautions that you can consider it if you have a patient would really need a special precaution. But actually, to be honest with you, most of these steps, it is a routine in our practice. Any question? Who asked about this? Yes. ask about this precaution? Sheila? No, okay, okay, got it. Any question? Okay, thank you very much. هلا والله مرحبا يا هلا مرحبا ها؟ Yes, for the
pigment distribution.
uh-huh.
Then once I have the stronger strands, like
Yeah.
the wide stronger strands, I can increase.
Yeah, you can go to 7, even 10, few shots. That's it. No problem with that.
Victor, another question.
Uh-huh.
Shadow exists.
أيوة. Again, yes, sometimes it's difficult to do beyond. You can go even a little bit more central. You don't need to go to the periphery. Yeah, you don't need to go to the periphery. So you go more central. هذا مرحبا. هلا هلا هلا.
This is not his, right? Assalamu alaikum. This is for him or?
This is for him.
For this, okay. Yeah, more.
No, a lot, because if not, I cannot.
Okay, this one. Where?
I will put it. Is it this your flash?
Yeah, that's correct. Now yeah, it's not, it's working or no? Or it takes time?
Let me see what happened.
It's a bit stuck.
Okay, it's hang. It's hang.
I hope it doesn't hang in during the lecture.
No, let me. So be smarter. Just.
Is there a lecture after this or finish? There is another one?
There's lecture.
No, this is for after us for the residents.
Ah.
Do we have after this? What we have? Dr. Zahur. Dr. Zahur, yeah, there is
One more.
one more.
What time?
It's until
Three?
3.
3 to 6 o'clock, I think. From 3 o'clock, Doctor.
We should start because
We can
then we have to finish on time.
Yeah.
Yeah, and now we're supposed to start 2 and now it's already late.
Doctor, not my job to call the people.
No, I will
It's
call.
not my job.
We will start. If they come, they come. If they don't come, they don't come.
When you start, they will come.
No, we can do like 5 minutes now. People
Yeah,
to
but,
rest, to eat something.
Even we are not
It's
ready.
the only time for eat something.
Exactly. You can wait 5
How long
minutes.
it will take? How long it takes? I hope it doesn't go too long. Maybe Lucy can say it.
No, no, no.
Working on features, they say 100% complete, but not complete. Sometimes this thing happened to my laptop at home. It take 1 hour.
We sent a mail to IT. This main, there is like 4 PC and 4 laptops in the hospital. Please don't let it update. Like this one. We will make a presentation. It's not time for update.
Yeah.
Yeah,
And
this
this
is
is from Windows system. You cannot.
exactly.
We ask IT to turn off, then let our laptops update. I will call him again now. I tell him.
So we don't have a second one now, another laptop?
We have.
Yeah, because if it is like this.
I'll bring it from my department. It's the same time if we wait.
Yeah.
Let me check inside.
Yes. This one, I don't know how long it will take.
اي والله والله قاعد يسوي update. اي والله. المشكلة اعطاني كمبيوتر 100% خلاص مهم. اسوي ستارت يشتغل. اي قال لي waiting 100% complete. Don't turn off. ID.
Okay.
اي طفيت اصلا. يلا مو مشكلة نكتب في المكتب راح برجع باقي ساعة. ها؟ اي طفيت وشغلت مرة ثانية سويت نشوف ان شاء الله يصبح ان شاء الله. ولا خليني اكلم الشباب. بسم الله خلينا نجوم بعدين.
This is open.
Yeah.
Why not? I can work. I say that we have technical problems. I can say that we have technical problems or not. For how long do you think?
I will call my colleague to bring the other one from there.
Good afternoon. Sorry, because we have a technical problems. We'll start a little later. Sorry for that. They will bring another computer?
Doctor, can you give me 5 minutes? I will bring it down.
Okay, maybe this one start. If meanwhile let's start.
What should I do? Stop here?
No, let's see if it is ready. Do not turn off your computer. Let's see.
This is.
What's your suggestion? Do you want me to go there?
Anyone can bring or
I've been calling Omar.
Yes, it's much
what he
better
says.
to bring another
Call?
one. Yes, because
bring.
this is again.
This maybe will go
Again.
for hours.
Yes, it's much better.
Tomorrow is coming or?
He was busy. He said, I will call you back. I will call you.
You sending this to IT?
No, to my group, MTV group, and IT also.
The computer is sleeping. It's like that.
Amar, my computer in the auditorium hang, updating. Can you bring another one or what? Yeah.
They close
new
the
one.
computer.
Yeah, tell him to turn on,
Auditorium, the main auditorium. Thank you.
tell him to on it from there so that it start.
Okay, you have it, laptop with you? Okay.
Tell him turn it
Thank you,
on
thank
from there.
you.
Tell him to on it on the way so that otherwise maybe that will take again time. Well, let's see. So he's coming.
Did you close the computer?
Where?
Close completely the
No,
computer
not
and
This
Yeah,
one?
yeah,
you
this
cannot.
Or that one? No, and
No,
that one
this
in the
one.
way it's very fast, new one.
But this one you close.
He
completely,
he
and
restarted,
yeah.
yes, but it didn't. It started even after restart. It's same.
Yeah. Oh, welcome.
Oh, it's coming.
Yeah,
See, we'll wait for this.
for welcome.
Let's connect and
No. We connect, and this time maybe it will hang again. Let's start, completely start, and we'll like this one because this one.
it's very slow. Yeah, excuse me. Thank you for waiting. We requested for another laptop. It is on the way because this laptop is not working well. Let's see. Try it again.
This one which will work.
It will work, but it's too slow. We should keep some good computer here because this is it's very slow.
Sir, Thursday, today is very a lot of request. All our laptop busy. All our like 6 laptops busy. In the end.
Okay, there's one. This one.
Here. This is
It's here. Okay, put in presentation.
what is this? You can start, I think, without wasting any more time.
Yes, we can start. Okay. Salam alaikum. Good afternoon. Welcome everyone. Today will be a different grand round performed with anesthesia department. Our topic will be a postoperative visual loss but in non-ocular surgery. This is a rare, unexpected, and sometimes devastating complication. Our lecture purpose will be incidence, risk factor, diagnosis of treatment of the postoperative visual loss. It's my pleasure to present Dr. Abdul Sahur Khan. He is a senior consultant, chairman of anesthesia department, and head of the operating room of the King Khaled Eye Hospital Specialists. And he's a fellowship from the College of the Physicians and Surgeons of Pakistan and diploma in cardiac anesthesia from the National Heart Institute of Kuala Lumpur, Malaysia. He has 17 years of experience in ophthalmology anesthesia, including teaching and scientific activities. I hope this lecture will be of interest for all of you. Please, Dr. Sahur.
Thank you, Lucia, for the introduction. And let's jump to the lecture directly because we are already behind our schedule. So I hope this topic or this terminology is not new for you because this is something related to ophthalmology, and but this is a complication which happened during anesthesia. So it's like a joint kind of thing that we both deal with. The post-operative visual loss, it's a condition, when I was a resident, let me tell you a small event that I saw in my career that I was, during my residency, I heard that there's one nurse who was working in the same hospital, and she had a postpartum hemorrhage, and she was resuscitated for a long time. She was unstable, but once she recovered, she said that she cannot see. And that was the time probably that this complication was not well known. And ultimately she recovered, but her vision never recovered to 100% of the original vision. So by definition, it is defined as like developing a partial or complete blindness after a recent anesthetic. So in majority of the cases, like the patient wake up from anesthesia and either the patient complained that the patient cannot see well or the patient absolutely cannot see. The first case was reported in 1976, but that time it was not well known that what it is. Maybe meanwhile there were many similar cases happened, but because of litigation reasons, the anesthesiologist, this is what they say, that it was underreported. But when the incidence of the complication went up with time, then it became obvious in the literature. In 1999, the American Society of Anesthesiologists, they established a registry, and they requested the anesthesiologists worldwide to report the cases without mentioning your name and without mentioning your identity. And that actually worked. And up to 2005, about 90 cases were reported to the ASA worldwide. And that number in 2020, that number reached to about 1,000. So now we have a database of 1,000 cases of postoperative visual loss. And my lecture is based on the analysis of that 1,000 cases. Okay, I can just quote you two recent papers. This one is in 2017, Revisiting Postoperative Visual Loss Following Non-Ocular Surgery. And the latest update is 2020, although the paper was first presented in September 2019. So this is the latest about this complication. Now, The anesthesia practice is not static. Actually, it's changing. And with time, the changes are good in a way that we can now perform very complicated procedures. But the disadvantage is that to do very complicated and long procedures, it has its own disadvantages. Although it is now said that the safety in anesthesia has improved a lot with time, because the monitoring facilities is improved. So we can now perform long and complicated surgery. For example, if you take an example of liver transplant, for example, the average time for a liver transplant is about 15 to 20 hours. So if a patient is on the table and, but that became possible with the safety of anesthesia. Now we are able to perform more controlled hypotension. Surgeries where there are risk of bleeding, we have now instruments and means to keep the blood pressure within a certain limit. One thing more which changed with time was that because of the complications of transfusion, with time we are now more conservative. We are now more conservative approach to the transfusion. So we are doing less and less transfusion with time, and that maybe have some advantages, but also have a disadvantage. There are some new anesthetic drugs in the market which are not good vasodilator, and that can affect the blood supply of some organs in the body, including the eye. One more thing that I would like to mention is the last point is about TIVA. TIVA is basically it's abbreviation which stands for total intravenous anesthesia. Now that is also a type of anesthesia where we don't use the traditional inhalation anesthetics. We use an infusion pump and give totally intravenous anesthesia, and that anesthesia has the effect on the cerebral vessels is that they are poor vasodilators. Okay, now coming back to the post-operative visual loss, this is the incidence that I took from this article, and although it may be not very accurate, but here you can see the incidence, and here you can see the type of surgeries which are associated with this complication. And you can see that starting from laminectomies without fusion, spine surgeries, knee surgery, hip surgery, spinal fusion surgery, cardiac surgery, and this is the incidence. But you can see the higher incidence of post-operative visual loss is with spinal fusion surgery and with a cardiac surgery. And the overall incidence so far understood is about 0.1 to 1%. What are the risk factors for post-operative visual loss? Does every patient that go through long and complicated surgeries, does every patient develop a post-operative visual loss? No. So the major risk factors is male gender, prone position surgeries, when the patient is in prone position, hypotension, especially if it is for long time, and then prolonged procedure and longer anesthesia duration. And one new factor they identified from this database is that those anesthesiologists who are not using enough colloid solutions, some anesthesiologists, they use only crystallite solutions. And colloid solutions are considered to be more balanced, and they stay in the circulation for longer time, so they keep the blood pressure relatively stable. So if you are not using colloids, that can be a risk factors to cause this complication. The minor risk factors are obesity, cardiovascular disease, hyperlipidemia, diabetes, smoking. Now, what is the extent of disability from this complication? It can start from a transient blurring or loss of vision, and it can go up to completely permanent blindness. Now, we classify this visual loss in two parts. Just for the ease of understanding, these are the complications which can happen. We call them visual loss with eye pain. And these are the ones which are without eye pain. Here the patient don't complain any pain. Now these are all of you know it more than me, so I will not go in too much detail. I will just briefly touch these, but we will focus mostly on these things. This is corneal abrasion acute angle closure glaucoma, and retobulbar hematoma. But these are the ones which are probably need more, because as ophthalmologists, you will be dealing with patients who are coming with this complication with you. So if we have this possibility in our mind that that can be a post-operative, something related to anesthesia, it will make your approach easy to the patient. So this is without pain is anterior ischemic optic neuropathy, posterior ischemic optic neuropathy, cerebral or cortical visual loss of vision, central retinal artery occlusion, and this is a very rare one, but it is also devastating if it happens. That is glycine-induced visual loss. So we will go briefly one by one, but before going that, I just want to show you the areas where this complication can happen. For example, this is the site. You see the lamina crebosa. If the defect is interior to this, we call it ischemic, anterior ischemic optic neuropathy. And this is if it is at the entry point of the retinal artery, so that can be the place where the occlusion can happen, and the rest is the posterior ischemic optic neuropathy. For the blood supply to the eye, to understand the ischemic neuropathy, this is very important. So I just only briefly refresh for the interior portion, optic disc and optic nerve within the scleral and canal or intracanacular. This is usually supplied by the short posterior ciliary artery. And then there is central retinal artery does not give any branch to the optic nerve in this region. So you see here the central retinal artery is going to the sides, but there is no supply to this area. And these arteries are the end arteries. They don't have any anastomosis. So if there is any defect in these arteries, that defect will affect your optic disc. The posterior portion or the intraorbital portion of the optic nerve, we all know that these are these small vessels. We call it pale vascular, sorry. Sorry for that. Okay. So, and these are the branches of ophthalmic artery, which supply the posterior part of the optic nerve, and compression or poor pressure in these arteries can cause the posterior ischemic optic neuropathy. The part of the optic nerve behind this is then again, it is supplied from pale network from the branches of the internal carotid artery and some branches from the anterior cerebral artery. Now, this is the a drawing of the whole visual pathway of the blood supply. So I will not go in the detail, but this is, as I told you, that the short ciliary arteries and central retinal artery are end arteries and have no anastomosis. This plays a role in this complication. But proximally, the ophthalmic artery has some connections with the external carotid artery. But again, those connections are not enough to prevent it from the ischemia. Now, this is a closer look of the optic disc, and we can see the short ciliary artery in its branches. And here we can see lamina crebosa. So anything defect interior to this will be labeled as anterior ischemic optic neuropathy. Okay, and this is the visual pathway at the base of the thing. So we already talked about this portion, but this is the area which is responsible for cortical blindness. And we will now see that how anesthesia contribute to the cortical blindness. Now, the causes of decreased blood flow or oxygen supply to the optic nerve, we can classify it in three types. First is failure of perfusion. And we understand that what is failure of perfusion can happen when there is hypotension. And especially if that hypotension is for a long time, like systemic hemorrhage. Or your blood pressure is normal, but there is a local vascular disease which does not allow the blood to go there. But the second part is increased resistance to the blood flow, and that can be like local arterial disease, like arteriosclerosis, if it is severe, or increased blood viscosity. For example, patient with polycythemia, chronic smokers, people living on a high altitude. So they are people who are prone for polycythemia, or patient with sickle cell disease. So they will give you more resistance to the blood, and that will result in a poor blood supply. And then increase external pressure on the vessels. For example, retrobulbar hematoma. And then venous engorgement, which is particularly associated with the prone surgeries. So that will cause swelling in the eye, and that will compromise the blood supply to the optic nerve. Thromboembolism or air embolism, that can be one of the reasons for the central retinal artery occlusion. But this is the important thing to understand from anesthesia point of view, that what is the perfusion pressure of eye and how we maintain it. Perfusion pressure of eye is equal to mean arterial pressure minus intraocular pressure. For an average person, the mean arterial pressure is 90. So let's say if we consider the intraocular pressure up to maximum of 20, this means 90 minus 20, your perfusion pressure in the eye is 70. Now, the literature says that if your perfusion pressure drops below 46, 45, 46 in your eye, that start compromising the blood supply of your tissues inside the eye. So we have to maintain a certain perfusion pressure to make sure that ischemia doesn't happen. And there is a third possibility of reduced blood supply is the oxygen carrying capacity of blood. That is something that your hemoglobin is normal, your blood pressure is okay, everything is okay, but still your tissues don't receive enough oxygen, and the reason is, for example, a patient polytrauma. Patient lost and we transfuse him 20 units of blood, and that is a stored blood. That stored blood have poor oxygen carrying capacity. Your blood is normal, your hemoglobin is normal, but it is not carrying enough oxygen. Or it is carrying enough oxygen, but because it is a stored blood, it does not deliver it at the tissue. And we call that in anesthesia language, we call it leftward shift of oxygen hemoglobin dissociation curve. Maybe you remember it from physiology. So if the curve is shifted left, the release of oxygen at tissue level become poor. Now, corneal abrasion, which is not a serious complication, but it can happen in any type of surgery, and the main reason is exposure of cornea during anesthesia or trauma. And it is common more with increased age. The onset is usually immediate. Usually it is unilateral. And when the patient wake up, this is what he complained: painful, foreign body sensation, conjunctival erythema, tearing, photophobia. It is fortunate that the prognosis is good, and usually we refer it to ophthalmologist, but using antibiotic or lubricant, it can cure it. But this complication has reduced with time, and in the last 10-15 years, this complication dropped by 50%. Acute angle closure glaucoma, I will not go in the detail because it's your field, you know it better than me, but I'll just tell you, during anesthesia, the reasons responsible to cause this is the use of adrenergic, anticholinergic, antihistamines, antiparkinson, cholinergic, antidepressant drugs. But does every patient develop acute angle closure glaucoma? No. It's genetic and anatomic variation, and some patients who are prone to it, they can develop this complication during anesthesia because of the use of these drugs and prolonged surgery. Its predisposition is more for female, and it is considered to be more unilateral than bilateral. The rest, I leave it to you because you understand it better how to treat it. We refer the patient to you. The retrobulbar hematoma, this is not a hematoma that is caused by the peribulbar block. Here we are talking about hematoma which develop spontaneously during anesthesia, either orbital trauma, head and neck procedure, especially if it is bilateral, orbital floor fractures. And those patients who are on anticoagulants, those whose blood pressure is not poorly controlled, Valsalva maneuvers, which is very common in anesthesia. We sometimes squeeze the bag and we give 1 liter to the patient. Nausea and vomiting can also increase the. Okay. The vision loss usually is 3 hours to 24 hours, but it can be delayed. Mostly it is unilateral. And What is the problem with this? That it causes optic nerve ischemia by direct compression, and it can even cause the occlusion of the central retinal artery. How to treat and what are the signs, symptoms, I leave it to you. We are coming to the main topic of today's presentation, and that is the ischemic optic neuropathy. For the ease of understanding, we divided it in interior ischemic optic neuropathy. The causes for interior and posterior are almost similar. And cardiac surgery, prone spine surgery, head and neck surgery, older age, vascular risk factors, anemia, the use of vasopressors. For example, patient after cardiac surgery, many patients, we keep them on epinephrine infusion. Sometime during the bypass procedure, when coming out from the bypass, we use vasopressors. If we use a very high doses, that can compromise the blood supply to the eye. And prolonged hypotension. Don't forget that hypotension and anemia are the two important factors. Okay, and there is a possibility of infarction at the watershed zone in the area supplied by posterior short ciliary artery. How they present, these patients? Usually immediate, but can be delayed up to 1 to 3 days after the surgery. And it is more bilateral, and the progress is for a few days before stabilizing, and the patient will have altitudinal field cuts, scotoma, to complete loss of vision with no light perception. Relative afferent pupillary defect, if asymptomatic or amerotic pupils. In the fundoscopic exam, you will find optic disc-swelling, poor vessel, vasculature, splinter hemorrhages, and the defect, the complication, usually it is permanent. There is a possibility of small recovery once it is well established. The diagnosis is based on this: history, symptom, light reflexes of the pupil, external eye exam, dilated fundoscopic exam. But the treatment, there is no proven treatment for it. The only thing that we can do is supportive, we can do is supportive, and that is like to optimize the hemodynamic of the patient, use of heavy doses of steroids, mannitol, and hyperbaric oxygen therapy. This is a relatively new type of treatment, but it is in use. This is in less severe cases, this is how the patient feel. So patient will experience post-operative vision loss, may have difficulty with activities involving looking down. And it becomes difficult for the patient, the everyday task. In more severe cases, it may change to this type. Now, this position for prone spinal surgeries, this frame is called Wilson frame. And among these 1,000 cases which they analyzed, they found that this Wilson frame is one of the most responsible factors for this complication. Because this patient will remain in this position for hours, especially the spine future surgeries. And it can be more than 6 hours. Because they say if the time of the procedure is shorter, the possibility of complication is less. Here, the head and the eyes are lower than the heart level. So that will lead to engorgement of the venous, poor venous return, poor venous veins emptying, and congestion into the eye. And that may be one of the reasons for the possibility of affecting the supply. Now, the posterior ischemic optic neuropathy is, again, the reasons are almost similar. One more thing that is not written in the previous slide is the prone Trendelenburg position. That is basically the head down position of the table. So if the head is down for a long time, that by itself can affect the supply of the eyes. And in this situation, mainly the spell, the small vessels, which are branches of the ophthalmic artery, that supply will be affected because that is easily compressible. And male sex and obesity they are more prone to it. Now, there is a little difference in the presentation of posterior ischemic optic neuropathy to the anterior ischemic optic neuropathy. The onset is usually immediate. As soon as the patient wake up from anesthesia, patients say, I cannot see. It is bilateral. The altitudinal field cuts and other complications are similar to the ischemic interior neuropathy. And the fundoscopic exam is normal. This is the difference. So the fundoscopic exam will become abnormal in later stages. In the beginning, the interior ischemic neuropathy, the fundoscopic exam is abnormal right from the beginning. Here, it is normal in the immediate period. So, but the loss is usually permanent, and the chances of recovery and prognosis is poor. Again, the diagnosis is this part, and the treatment is, again, there is no known proven treatment, but theoretically to optimize your hemodynamics, mannitol to reduce the IOP, and hyperbaric oxygen, and steroids. Now, the cerebral or cortical visual loss is now different from the optic neuropathy, ischemic optic neuropathy, because it involves the center of the brain. And again, it is more common in spine fusion and cardiac surgery, and also in some prolonged orthopedic cases where we cause hypotension, deliberate hypotension to reduce blood loss. One thing which is new here is that it is more common in less than 18 years of age. And the reason is the small infarctions due to emboli and hypotension. The presentation, onset is immediate after emergence from anesthesia. It is bilateral. Total blindness or small preserved central vision. And this is contralateral, unilateral, contralateral. How you pronounce this word? I tried a lot, but I don't know, I couldn't read it. You call it how you pronounce it? Okay, so probably what I understood, it is something like this. I'm not ophthalmologist, so don't expect me, I will know it, but anyway, but this is what they say, that this is how it presents. And the hemianopia, pupillary light reflexes are normal. Fundoscopic exam is also normal. There is possibility of some recovery if you diagnose it quickly and you restore the hemodynamics and electrolytes and everything to normal faster. The diagnosis here is not on history and local exam. You have to go for a CT and MRI to understand. The treatment, fortunately, in this case is easy because you need to improve the cardiac output, bring the blood pressure to normal, and improve the oxygenation. So they say that the recovery chances in this case are more than the ischemic optic neuropathies. Now, this is the last complication, which is central retinal artery occlusion. And again, these are the kind of surgeries which are the responsible, prone procedure, especially spine, cardiac surgery, head and neck surgery, embolization. This horseshoe headrest is something similar to that Wilson frame. So if you keep the patient head in that position, in the prone. And one more thing which can cause this is the use of nitrous oxide for a long time, because nitrous oxide is a gas that we use during anesthesia, and by itself it can cause not only embolization, but it can increase the size of air bubbles anywhere in the body. It can increase the size of a bubble up to 20 times the normal size of that bubble. So that can be responsible for the retinal artery occlusion. The presentation is immediate after anesthesia, and it is unilateral. Okay, the complete or nearly complete loss of vision in the affected eye, and the light reflex is sluggish or absent. Relatively afferent pupillary, if caused by globe compression, may have signs of periorbital trauma. Now, retinal whitening on fundoscopic exam. You people know it better than me. The damage usually permanent or severe visual loss in the affected eye. This is how you diagnose this. And the treatment, theoretically, there is one thing that I want to mention here. The rest you people know it. That is the inhaled oxygen with 5% carbon dioxide. That is one of the recommended treatment if there is central retinal occlusion after anesthesia. CO2, if you use it as a therapeutic, inhalational, it causes vasodilation, especially cerebral vasodilation and into the eye. And it expects that it might increase the size of the retinal artery, and probably that embolus is either pushed for, or if it is air, it can circulate and can go. Okay, now this is a rare complication, but you may see or you may have a referral of a patient after transurethral prostate resection operation. We call it TURP. Because the urologists, they use a fluid called glycine for irrigation of the bladder. Even hysteroscopy also, they use this fluid for irrigation. Now this fluid, glycine is basically a protein. Yeah, but if you use it for a long time and you are cutting the prostate, you are opening the veins, this fluid is absorbed tremendously through the veins, goes into the circulation, causes hemodilution, and causes severe hyponatremia. And this leads to a complication, we call it glycine-induced visual loss. If it is a general anesthesia, the patient will complain after waking up. If it is a spinal anesthesia, even during surgery, the patient can tell you, my vision is blurry, I cannot see well. And usually, this is how they present. Blurred vision, sluggish to fixed and dilated pupils. Fundoscopic exam will be normal. And in less than 24 hours, maybe longer if severe hyponatremia, so the complication will stay for up to 24 hours. The diagnosis is history lab, serum glycine and ammonia level, because ammonia is the metabolic product of glycine. And the treatment, again, the prognosis is not bad here, and to correct the overload and electrolyte balance, and most of the patient, they recover. Now, here you can see before it was thought that probably glycine causes the visual impairment because of hemodilution and because of the hyponatremia. But now they say no, that may play a role, but glycine itself have a direct, it's the major inhibitory neurotransmitter in the CNS and retina, so it has a direct effect on the retina. Maybe this sodium or hyponatremia maybe have some minor role. Okay. This is the, okay. I cannot explain this well, but what you see here, I don't know. Okay. Okay, now this slide, I just want to tell you only here that in the ischemic optic neuropathy, 89% of post-operative visual loss is because of interior ischemic optic neuropathy. Posterior is less. More is anterior. And this is the general supportive treatment if you receive a patient here. High dose of IV steroids for 2 days, minimum. Retrobulbar steroids, maybe through a block or maybe through peribulbar or retrobulbar needle. Mannitol, acetazolamide, anticoagulants, because that may improve the blood supply to the blocked arteries. Aspirin plays a positive role. If there is anemia, replace the blood. And use vasopressor if the hypotension is sustained and it's not coming up. Optic nerve decompression in hemorrhagic case for posterior ischemic optic neuropathy. But it is optic nerve decompression for interior one is not effective because the problem is in the interior part. Surgical optic nerve fenestration, they say it is under trial, but this study is old. Maybe now it is established, I don't know. Maybe it's, but in this study they say that it is under trial. And still in ganglion block can play a role for up to few hours. It improves the supply of the eye, the blood supply of the eye. Now, early interior ischemic optic neuropathy will display an abnormal optic disc. Early posterior neuropathy will display a normal optic disc. And here, the interior portion of the optic nerve receive less blood, edema, and that edema can last up to 2 to 3 months. And then early interior ischemic optic neuropathy will display an edematous optic disc, but in posterior, in this case, this appearance, this will be in a later stage, not immediate. And atrophy, an atrophied nerve results in permanent, possibly extensive visual loss. In these both situations, interior neuropathy will display an atrophic disc, optic disc, and in this case, late posterior neuropathy will display an atrophic because it will take time for atrophy to happen. Now, here, just the difference in the fundoscopy, for the ischemic optic neuropathy, you will see the signs immediate, but in the posterior, you will see it delayed. For retinal artery occlusion, pale retina, cherry red spot at fovea. For cortical blindness, the fundus will be normal, and the venous obstruction, it will be similar to retinal artery occlusion. So to summarize, post-operative visual loss is a rare but devastating complication. A patient needs urgent ophthalmology consult if complain visual impairment after major non-ocular surgery. Ischemic optic neuropathy is associated with the cardiac bypass surgery, prone spinal surgery, non-fusion orthopedic procedures, head and neck procedure, and prolonged procedure performed in steep head-down position. Risk factors are male sex, obesity, use of Wilson frame, prolonged surgery duration, age more than 50, and high blood loss, severe blood loss. Cerebral visual loss is most common in procedure with high embolic loads or profound hypotension, such as cardiac bypass, prone spinal fusion, or non-fusion orthopedic surgery. And the central retinal artery occlusion is caused by embolic phenomena or by globe compression and should be suspected in the patient who awaken from anesthesia with severe unilateral visual loss or without periorbital trauma. Early diagnosis can help the patient, but once happened and established, the prognosis is poor. No definitive treatment is available so far. And these are the recommendations basically by the American Society of Anesthesia for anesthesiologists, but I'm sure it is useful for the ophthalmologists also to know about it. To position the head in a neutral position and above the level of the heart for prone position surgeries. So don't keep the head of the patient lower than the body when you position him for spine surgeries. Avoid direct pressure on the globe to prevent central retinal artery occlusion. Maintain mean arterial pressure with 20 to 25% of the baseline. So if a patient baseline blood pressure is 120, we should not allow it to fluctuate more than 25%. If it drops more than 20 or 25%, the possibility of complication will become more. Use colloids together with the crystallite solutions. Keep hematocrit at appropriate level. Now, appropriate is a very vague terminology. What is appropriate? 10, 11, 12, 13, 14, we don't know. Depending on the situation, depending on the length of the surgery, depending on the loss of the blood, how much blood is lost. So, depending on the availability of blood. So that is why we say use appropriate level. But the anesthesiologist in the last 20 years, the practice is that they don't want to transfuse unless it is extremely necessary. But if you are going for a long procedure, particularly the literature say that if your procedure is longer than 6 hours, there are chances of this complication. Surgery is shorter, like 1, 2, 3 hours, there is less possibility. Assess post-operative vision in high-risk patient as soon as possible. If you suspect that this patient can develop this, and suspect central retinal artery occlusion if a patient awakened from anesthesia with unilateral visual loss or without periorbital trauma. Aspirin, all the studies say that aspirin is useful, it is helpful. So thank you very much. Questions?
Thank you, Dr. Sahur. I hope there are a lot of questions about that. Okay. Thank you.
Thank you so much, Doc, for this
Thank you.
Interesting and overlooked often topic. My question is regarding any precaution for the anesthesia or any type of anesthesia you recommend for patients with advanced glaucoma to avoid any post-operative visual loss that can be happened?
You mean a patient going for some major surgery, but the patient have the patient also have a glaucoma?
Exactly, and very advanced, and we're going to operate on the eye. Is there any specific type of anesthesia is better than other?
Okay, so this now, if I understood it correctly, your question is not related to this topic. It is what are the precautions to be taken for a patient with an advanced glaucoma going for surgery?
Exactly.
Okay, now again it depends if it is a general anesthesia or if it is a local anesthesia. If it is a local anesthesia, there is very little in our control. But if it is a general anesthesia, yes. What I can understand, what I can tell you is that all the anesthetic drugs in IV or inhalational, or there are just 1 or 2, 3 drugs which increase the intraocular pressure. The rest, all of them, it reduces the intraocular pressure. For example, ketamine is a drug which increases the intraocular pressure, right? But the rest all, they reduce. There is one muscle relaxant that we use that is called succinylcholine. That increase the intraocular pressure. But all other drugs, to my knowledge, they reduce the intraocular pressure. What we have to be careful about is that to keep the blood pressure under control, because the intraocular pressure is directly related with the blood pressure. So if the patient is hemodynamically stable throughout, that will prevent any rise. Don't allow the patient to become light. That is a possibility. So now we have a system which is also now available with us. We can measure the anesthetic level in the brain by the monitor calculated for us, and it gives us a range to keep the patient within this range. Mistakes and errors can happen, but this is the things what we can do.
And is there any superiority for specific type of anesthesia regarding minimizing the blood circulation to the optic nerve? Because in case of glaucoma, advanced glaucoma, there is a risk of wipe-out syndrome, what is called wipe-out syndrome. That is the patient in very advanced glaucoma might we have visual loss post-op, and this is reported in the literature. But is there any specific type of anesthesia that, because they told might be the blood supply to the optic nerve, it can be affected during the anesthesia? So my question is there any specific type have the least affecting regarding the blood supply to the circulation for the optic nerve?
I think no, because the anesthesia going for other procedures, it's a standard, and that standard anesthetic you need to use for all type of anesthetics, excluding a few. We have some manipulation in the drugs and the doses and the techniques, but in general, I don't think there is anything in particular to improve the supply of the optic nerves.
So if I'm going to choose with subtenon or pilibarber, shall I go with subtenon in case of advanced glaucoma, or it doesn't differ?
The subtenon block is known to, see, there is the peribulbar or retrobulbar block also increase the pressure, but that pressure increase is extraocular. We call it intraorbital pressure is increased with the peribulbar block, not intraocular. This means it is putting the pressure on the globe from outside. For peribulbar, because, for subtenon, we are going in the tenon capsule, which is just behind the globe. If you build up pressure there, that is like a kind of increasing your, so the subtenon block is known to increase your intraocular pressure, but the literature say that is very transient, and within 5 minutes, the pressure come back to the baseline level. Yeah.
Thank you so much.
You're welcome.
Also, I would like to add, also it's important the position of the patient. Okay, need the head to be neutral and also the chest a little rise. Okay, not in complete supine position. This kind of patient, I think for all of our patients, it's important to stay the head a little up. Okay.
Yeah, the little slightly head-up position that helps in improve the venous emptying from the head, and that prevents engorgement of the venous system.
More questions?
Any other question?
Okay, I would like to ask. No, I was surprised about one thing. Yes, is why patients with are under 18 years old have more risk of cortical blindness. Do you know?
No, I searched for it. That is a question for me also, because usually young patients, they are considered stronger, their vasculature, their body system, everything, they can resist more. I didn't find any answer that why it is more and less than 18. But this is what the database that we have, this is 980 cases, and that is the analysis of those. Those database, it tells that it is more and less than 18 years of age. But I can tell you about an animal studies. There is a study done in the rates, and they say that the animal study, that it is, I think it is, yeah. So I don't know the mechanism. I'm not aware why it is like this, but it is in less than 18.
I don't know if there are some pediatric ophthalmologists that can help us or another, because this is for me, I don't understand. I try to check in the literature, only say that this kind of patient have more risk, but I don't know why. Do you know some ophthalmologist? What is the reason? For cortical blindness, no? Because for all patients you can understand the pathology, but for younger patients, no?
I also don't know.
Okay.
So, finish?
Any more questions, no?
Thank you very much. Thank you for listening, yes.
Thank you.
Yeah. Thank you. We wasted some time, so yeah, so I tried to go a little far. Okay, so we finish within time, yeah, good. Thank you. Why you did not ask this question? No, time is over. I will not answer now.
Assalamu alaikum.
Good. Oh, welcome back. How are you?
Fine.
Great. Nice to see you again.
Thank you.
Do you have a lecture next?
Yes.
Oh, great.
Thank you. ممكن نشيل اللابتوب هذا بس عشان ما يتزحلق لابتوبي.
خلينا نسوي حركه ذكيه. لابتوبك اتش دي صح يا دكتور؟
شلون؟
لابتوبك اتش دي وسط اتش دي.
اي اتش دي. عوض فوق له. My patient after demic, 5th day, when the air become 30% or 40%, 20-30 vision. It was hand motion. But I did it with قطامش not فوق له.
Okay.
But
I have one patient. She is 2030. She was not happy because she was artisan. I removed the artisan. And she said, "No, my eyesight is well." I said, "Because." And she went privately to see someone, and he said, "No, you didn't have a transplant."
the same happened to my
You
friend.
didn't do my colon transplant.
Same happened to my friend in Canada. هذه حقتي؟ لا هذه حقتي. In Canada, he saw one patient after combined, and he told the patient, "No, the one is fake." She said, "No, combined." He said, "No, it's fake." The consultant was about to kill him. How come?
She said,
He said,
I went to someone in Abha, and then he went to another private in Abha, and they said, "No, you didn't have a transplant."
in heaven. No, because first day.
This is me. Good, excellent. It's already there.
Sorry. Doctor, sorry.
This is your. I hate.
What do you want?
No, that's fine. I just
You
wanted
want?
to- I just want to see. Our option is even gone. It's not even there because now we have MS39 OCT. No one better? I think they all know about Pentacam, isn't it? Good afternoon, everyone. Shall we check if someone is outside there, or we can send Hamad? This is the third one, isn't it? This is the third time we are doing it. This is fourth? No. 17.
19, 20.
Yeah.
I think.
No, third, I think.
Okay, there. Okay. I have a copy for each year with a date. So I will check.
Yeah. I think it's third one. I think we should start. Good afternoon, everybody, and thanks for coming to this third annual Pentacam review course. And Dr. Turki has been of a great help to us, and he had an excellent presentation for about 2 hours, I would say, isn't it? And he will talk about all the different indices and all the different parameters which are there in Pentacam. I just want to emphasize a couple of things that what we should know about. Like, first of all, I mean, the world is not just Pentacam. There are millions of other topographers still there. And how many tomographers we have got at the moment here in the hospital? Which one we have got here? And not the F1s, not the fellows, okay? Residents. OBSCAN is out, anyhow. Galili is there at the moment. Pentacam is there. Anything else? Yes, who said that? Oh, again, you are, okay, oh, you, good, very good. So where is it? Because I showed it to you other day. So it's with our machine, the Schwein. So it works there. So which one is better? I mean, one can always argue that maybe Galili and Sirius are better than Pentacam because they have got an inbuilt Placido. They don't use a reference, and they have got a dual camera to decrease the parallax. But the main point with Pentacam is Pentacam has got a history of 20 years plus years. So they have generated a lot of algorithms, and based on that, they have generated all these indices, which Dr. Turki will go in details. And by the end of the course, everybody should know all the indices, all the numbers by heart. I'm joking. And it's very important, and it's a huge list, and it's very daunting, and sometimes even for me, I mean, every new upgrade, there is a new number, and a new sort of a index, and sometimes you know what is this, and then looking for the exact number, the cut value, and then there is a huge sort of a sea of knowledge to look for which cut value is the cut value which you should use. Is it 0.5, 0.65? It depends on the study was done in Iran or Barcelona or Brazil or States. So the aim of these indices is that, first of all, it's not the one index you have to look for. The patient comes and you say, okay, your corneal thickness is 495. Okay, that's it. You have got keratoconus. Or the patient comes with a K max of 47.9 or 48, and you say, okay, that's it. You have got keratoconus. His thickness may be 600. He could be a good candidate for refractive surgery, and you will not do it. So every index or every parameter has got a sensitivity and specificity. And ideally, it should be more than 90% to be valid. okay? And how these validations comes, I mean, they all come from, they have done X number of cases of refractive surgery or X number of patients they have followed, and they found out, okay, 0.4 is good rather than 0.42. So any test, I mean, you should all know about this curve. This is the ROC curve, and anything going up becomes sort of more accurate. And we all know about what is specificity and sensitivity of the test. So it's very important that if you increase the sensitivity, the specificity will decrease, isn't it? Let me give you an example. Let's talk about the displacement of the thinnest point. What is taken as a cut line? No, displacement of the thinnest point from the apex. Yeah, so anything below 0.5 is taken as no keratoconus. Anything more than 1 is definitely keratoconus. Anything in between is suspicious. And this is the gray area. So let's suppose we make it 0.4, which means it is very sensitive now. Any patient who has more than 0.4, we call it keratoconus. We will not do refractive surgery, and none of your patients will develop ectasia, isn't it? Because the sensitivity is now almost 100%. Good side is that none of your patients will develop keratoconus, but the downside is your private practice will go down. You will not be doing all the cases. So then you need to find a balance. And on the other way, if you increase the specificity, or let's say, if you say 0.4, it means any patient who is more than 0.4 is keratoconus. What does it mean? You will tell them that you have got keratoconus. I will do a cross-linking. And in actual fact, he may not be keratoconic. So the positive side is, okay, you're not harming anyone, but here you may be over-treating patients. You may be doing cross-linking, or you may be telling a person who wants to be in a Royal Air Force that, no, you cannot go to the Air Force because you will develop keratoconus. So Turkey will talk about different indices and different parameters and to find out which are the best one. But this is the list according to a recent review published sort of 3 months back. For keratoconus detection, these are the 4 which are in the descending order. And for keratoconus progression, these are the 3 which are in descending order. So with that, we all welcome Dr. Turki, who has come from, how far is military hospital? 10 miles? Yeah. So if we can welcome Dr. Turki for his presentation.
Assalamu alaikum. البرزنتيشن طويل ولكن 2 parts. البارت الأول بيتكلم عن general concepts والبارت number 2 about Pentacam only. طيب بسم الله. So to start with, we will start with topography or tomography, which one is correct terminology for our machines nowadays. So the corneal imaging, we have reflection-based technology like Placido reflection, keratometry, and topography, or what's called computerized video keratoscopy. And also we have projection-based technology like tomography. We have scanning slit tomography with topography like Orbiscan. We have rotating shame-flag image or shame-flag tomography only, like Pentacam. And if we combine this rotating shame-flag tomography with topography, we have with the single camera, Cirrus, Tommy, and Persio, and the dual rotational camera, we have Galilei. So Pentacam, only tomography, but Cirrus, Tommy, Galilei, and others, they have topography as well. Also, we have OCT tomography like Cassini. So usually the shame-flag image, what does it mean? It means a camera that rotates 360 degrees around the eye to take a picture of the cornea within 2 seconds. If you have a patient, for follow-up, let's say he presented today and you will follow up the patient after 6 months, you cannot follow the patient with Orbiscan then Pentacam. It should be Orbiscan to Orbiscan or Pentacam to Pentacam. So it is not interchangeable. The difference between topography or tomography, the topography measures only the anterior surface, so the axial, tangential map and anterior elevation map. Whereas tomography, it is a 3D image. It's anterior and posterior surface. The bachymetry, usually not measured with the topography, but tomography can measure it because it is a 3D as we mentioned. And also it gives a thickness profile. The coverage, topography covers only less than 9 millimeter of the cornea, whereas tomography, it covers limbus to limbus. So you can detect the pellucid in the, like ectasia in the margin and white to white and measure white to white. The topography, it is very sensitive to large angle CABA, misalignment, and tear film disturbance. So if you have a patient with the dryness, usually topography will give you false positive results. Whereas tomography, it is less susceptible to large angle CABA and misalignment, but it is very sensitive to corneal scars. So if you have a corneal scars and if you use Pentacam to evaluate corneal scars, sometimes it will give you very thin cornea, 100 microns. But in reality, if you measure it with OCT, it is more than 100. The corneal haze and scar, as we mentioned, it is better to be taken by topography. That's why some machines, they combine topography with tomography. And the tomography is better in patients with tear film instability. The AC depth and lens analysis can be measured only with tomographic machines. And the machine is relatively expensive, the tomographic machine. So what are the uses of tomography? Usually we use it to screen for refractive surgery, early or subclinical keratoconus, to detect early progression of ectasia, toric IOL planning, IOL calculation. In my practice, I'm using the Pentacam for all patients that they will go for cataract surgery. All patients, not even post-refractive or cornea scar or irregular cornea, because sometimes we have irregular cornea, but it is clear, no obvious scar or something, but it is irregular cornea. So I'm doing the IOL calculation with Pentacam for all patients. And usually every clinic, I will be surprised, or I'm surprised with the difference between the K readings that I got from the Pentacam and the IOL calculation. So really it can save your day. So, and we have a Pentacam AXL, which also measures the axial length of the eye, so you can do your IOL calculation with the Pentacam alone, no need for other devices, biometric devices. Also, you can diagnose the peripheral corneal disease like pellucid, corneal wavefront, and last year they released Pentacam AXL wave, which include also the ocular or total wavefront, and we will talk about them. Also, the Pentacam AXL wave can give you objective refraction before and after surgery, lens evaluation like BNS, a glaucoma assessment for AC depth and the angle and the volume of the anterior chamber, AC depth also. By using full bachymetric mapping, you can plan for the patient with folks that they should go for phaco alone or combined phaco with demic or DASIC or endothelial keratoplasty in general. Also, it provides corrected intraocular pressure, planning for depth of intrastromal rings insertion or AK. So let us start with this example. Mention the type of astigmatism. Who wants to answer this? What is this ring? Can you name the rings? Placido. How can we get this ring? Which machine will give you this ring? Or which device or instrument? NOR, if you want to get the Maloney ring. Yes. So what type of astigmatism? Many legal with the rule, against the rule. With the rule, against the rule. Why against the rule? Steep here, huh? On 180. Okay. Which refraction match this Placido or rings? B or A؟ طيب اللي يقول A B يعني 50% B 0% A 50% ولا شيء. طيب if you want to know طيب خلونا نبدأ الحين. A, what type of astigmatism is A? Is it against the rule or with the rule? Why with the rule? Minus on 180. For me, usually I'm following the plus. I will convert direct to plus, and plus usually will give you the axis. Okay? So the B, if we convert it, the axis is 180, so B is the correct answer. Clear? So this is against the rule, and this is with the rule. طيب, another quiz. What type of astigmatism? This is intraoperative. And what is this? What is this? Hey, Maloney ring. طيب. With this ring, we can get this image. So what type of astigmatism? Inferior steepening. So steep cornea, this is the cone usually. Okay? Clear? So we'll start with the definitions. The form frost keratoconus. There is no consensus about the form frost definition. So we have different definitions for keratoconus. And if you attend different clinics with different consultants, each one will give you different definition. But usually, and most commonly used is the first one. It's the clinical or tomographic keratoconus in one eye, and the other eye is normal. But others, they called the tomographic keratoconus in both eyes with normal slit lamp examination is form frost. Or preoperative tomographic of actual post-LASIK ectasia. The fourth definition is normal tomography with positive family history of keratoconus. But usually we are following number one, but not necessarily. Which one is steeper, A or B? يلا اللي يقول A. Why? No, you can't tell. Radius of curvature. This is circle. It is not aspheric. It is spheric. So usually the base curve or the radius of curvature is the same. It is spheric. It is circle. It is circle. No, it is circle. This is circles. So you can't tell. So if it is 8 or 6, which one is steeper? Just remember that. The one on the 6, he can finish the term faster than the one on the 8. Okay? So 6 is steeper. So this is an example. Let's say the radius of curvature is 6.75 or 8. Which one will give you higher K readings? 6. And how can you convert the radius of curvature to K readings? It's very simple. 337.5 divided by the radius of curvature. So the radius of curvature of 6.75 is 50, and the 8.43 is 40. Clear? So the steeper is 1 or 2? 2. طيب. If you, another example, if you plan toric IOL at 130, axis 135, for both eyes, which one you will select? 1, 2, or 3, or 4? Hmm. 2 and 4. 2 and 4. Clear? Because the 0 is usually here. Regardless of the laterality, right or left, usually here is the 0. Clear? So if we will talk about now the coordinates, we have 2 types of coordinate. Cartesian, this is in Pentacam. Other machines, they have both polar and Cartesian. This is XY and this is polar. So the polar depends on the distance from the center, or R, and theta angle. And usually the theta will start here from 0, regardless of the laterality, and you have to follow the angle. So if it is 60, it's here. If it is 210, it's here. The one used in Pentacam, it's XY. Here is the X, and here is the Y. And this is plus, regardless of the laterality. Clear? So this is an example, regardless of the laterality, and this is the example of polar coordinates. Clear? Because different machines use different coordinates. Like Cirrus for Schwind, you can select which one do you prefer. If we go to math, polar is more accurate for the shape of the cornea. But it's very complicated and sophisticated, that's why they used XY. Okay, clinical markers for centration of refractive treatment and devices, like IOL trifocal. We have angle kappa and angle alpha. What is the difference between angle alpha and angle kappa? أي أحد يبغى يجاوب؟ Angle kappa is the angle between visual axis and pupillary axis, whereas the angle alpha between visual axis and optical axis. What is optical axis? Center of the cornea, yes. So the geometric center of the cornea is the optical axis. So if you want to center your trifocal IOL, you should center it on first Purkinje, just between first and fourth Purkinje, which is the visual axis usually. But if you have large angle kappa, sometimes you cannot center it on the visual axis, even if you follow this, the first Purkinje, if it is very large. Okay, angle kappa, it is the angle between pupillary axis and visual axis. Normal angle kappa is slightly temporal. It is important in trifocal IOL, hyperopic ablation, and if the astigmatism is more than 1 diopter. So if we follow XY coordinates, usually the positive coordinates will be on this side and this side. We agree on that, right? This is X axis. So here, this is minus 0.22, and here plus 0.34. So it will be temporal or nasal? Temporal in both. So here, it will be temporal in both. Okay, because we are follow the XY coordinates, and it is regardless of the laterality, it is XY coordinate. Clear? So now we will talk about the aberrations. We have different types of aberration. We have low order aberration, which is also called second order aberration, versus high order aberration, which is irregular astigmatism. Do you know what is low order aberration? Yes. So myopia, hyperopia, or astigmatism. Also, we have corneal aberrations or internal aberration, or the ocular, the total. So this is the Zernike polynomial, and usually the low order aberration or second order aberration is sphere and cylinder, usually corrected with the glasses or regular contact lens, not the hard one. Usually we have defocus. This one is defocus. Is it clear? The defocus is myopia or hyperopia. And you can get this map on all the tomographic machines, okay, to analyze the high order aberration and low order aberration of each eye. So this is, which one is hyperopia or myopia? This is hyperopia, this is myopia. And this one is the astigmatism. So astigmatism, myopia, hyperopia are among second order aberration. High order aberration, we have different high order aberration, more than 15 order. But our concern or the clinically significant is spherical aberration, trefoil. Usually it is not corrected with spectacles. So if the patient complaining of night vision problem, that he's seeing glare or halos, first thing you have to ask him about the complaint while wearing the glasses. If it is completely resolved or no. If it is resolved, what does it mean? It is second order or low order aberration. If it persists, high order aberration. Is it corneal or internal? Means lenticular. You cannot tell. How can you? Hard contact lens. Hard contact lens, if it is resolved with hard contact lens, means it's not related to the cornea. It is related to the cornea. If it is even with hard contact lens still there, means it is internal. It is in the lens or others. So it can be corrected with hard contact lens. So, and these are the high order aberration. طيب هي الموضوع بسيط. لما نشوف هذه which one is this يعني this one match which one. خلونا نبدأ بهذه. هذه ايش؟ هذه التوبوغرافي حقتنا. طيب تمشي مع أي واحدة على هذه صح؟ فvertical comma. Clear? This is the way how to interpret the Zernike analysis or high order aberration. And this one, huh? Lay vertical astigmatism. This is 1, 2, 3. So it is 1, 2, 3. So it is trefoil. Clear? Ziyad clear? See here, 1, 2, 3. Okay? And here, 1, 2, 3. So it is trefoil. Which is more significant clinically? The patient will complain about trefoil or coma? Coma. And coma usually comes with which disease? Keratoconus. Okay. So if you see this axia خلاص جاوبتها. طيب فهذه vertical coma. Okay. طيب وهذه زيادة تترافويد. خلاص. طيب هذه spherical aberration. طيب spherical aberration, this one. So the coma is usually from the comet and trefoil, this coma and trefoil third order aberration, whereas spherical aberration is fourth order. And this is the Mexican hat is the spherical aberration usually, the appearance on the tomography. Okay. أي واحدة تتوقعون إنها يعني تأثر على الشوف أكثر؟ أي واحدة تأثرت؟ A ولا B ولا C؟ طيب A أكثر واحدة، بعدها C. طيب A it's a comma trefoil spherical aberration. Clear؟ طبعا هذه حتى بالنظارة ما تروح، فيبقون زي كذا، فكذا يشوف الكيراتوكونس. طيب فالكوما is the most significant, followed by spherical aberration and then trefoil. طيب corneal shape. If we classify the shape of the cornea based on Q value, we have circle. When the Q value is 0, it is a circle or sphere. When it is between -1 and +1, it is ellipsoid cornea. When it is 1 plus or minus, it is parabolic. When it is beyond or larger than minus or +1, it is hyperbole. Clear? Based on the Q value also, if it is less than 0, it is negative Q value, so the shape is prolate, and we will talk about prolate. If it is more than or plus in plus value, it is oblate. Okay, we have to correlate this Q value to the spherical aberration. What is the normal Q value in our eyes? Is it negative or positive? Negative. And the normal spherical aberration? Positive. طيب positive for the corneal. Okay. طيب كيف عرفنا انها positive؟ positive لأي distance؟ positive لل 6 ملم أو infinity تتسمى. فهنا نحسبها هذه. فالسفيريكال ابريشن is calculated على الانفينيتي، ما هي على النير. طيب ففي بعضهم ممكن انت تشوف السفيريكال ابريشن is excellent، بس لما يقول لك لا انا على مثلا انوار مختلفه ولا على بعد مختلف، تختلف عند السفيريكال ابريشن حتى لو الكورنيا مطلعت لك اياها كويسه. طيب فالنيجاتيف spherical aberration when we say negative spherical aberration when the Q value is less than minus 0.528 or in the other references minus 0.55. If it is below this number, it is negative spherical aberration. If it is more, it is positive spherical aberration. And usually our brain can tolerate positive spherical aberration but cannot tolerate the negative spherical aberration. Okay, so the ideal sphericity of the surface is to eliminate the spherical aberration at distance object, therefore our cornea prolate ellipsoid, and as we mentioned, it's at infinity. So the mean Q value in the normal population is Q value is minus 0.26. This is the mean value, okay? But it is not the only one normal, no, we have a range. But the mean is minus 0.26. So the Q value of minus 0.26 indicates positive spherical aberration, right? How much is positive? Plus 0.27. If we subtract this one from this one, we will get 0.27. Clear? Clear? لأن ترى السلايدز اللي بعدها كلها تعتمد على هذه. إذا فهمتوا هذه خلاص. Clear? طيب. The mean or the ideal or the perfect Q value at 6 millimeter is minus 0.26 in normal human eyes. In young, healthy adult. If we have this Q value means the spherical aberration in this eye is plus 0.27. Clear? طيب ليه ربي خلقها بلس؟ ليه ما خلاها الصفر؟ لا هذه من البروليتشي، بس ليه ربي خلقها كذا؟ أيوة، من اللي جاوبها؟ أي. طيب أول شيء عندنا the amount of spherical aberration has direct influence on the quality of vision and the focus of image. بمعنى لو واحد عنده spherical aberration 0, okay, so here if the spherical aberration is 0 and let's say he's aphakic with 0 spherical aberration and the refractive error is let's say emetropia because high axial length, so it will produce sharper image but shallow depth of focus. But the advantage of spherical aberration, either positive or negative, is to enlarge the depth of focus. طيب متى نحتاج enlargement of depth of focus؟ كيف؟ أيوة في البريسبيوبيا. فلما نشوف واحد كبير أكيد نربي حاط له spherical aberration بالبلس أو بالماينس، ما فيها كلام. واضحة؟ فبس الزيرو بيحتاجها اليانج لأن عنده accumulation، ما يحتاج السفيريكال aberration. فعشان كذا في الكبار في البريسبيوبيا يبدأ ربي يغير لهم الانتيكولر عشان يطلع لهم spherical aberration plus or minus. طيب. So the Q value, it represents the corneal sphericity or the shape of the cornea. It's spherical or aspherical. The spherical when the center equals to the periphery, so it is circle. Aspheric when the center is larger or less than the periphery. So if we have, let's say this IOL, thickness, aspheric IOL. What does it mean, aspheric? It is not spheric, but what does it mean? أتوقع كلكم تستعملون aspheric IOL. ما حد فكر وش معنى aspheric؟ كيف؟ طيب هذه الاي او ال. فالاي او ال هنا في النص غير في الطرف، فهذه aspheric، فمعناها it induce it induces spherical aberration that it will compensate the corneal aberration, like a lenticular, like our lens. If it is spherical, the spherical aberration will increase because the IOL will not compensate for spherical aberration of the cornea. سم. الحين بجيها. لا different. كل IOL لها sphericity معينة غير الثانية. مختلفة. لها لو تشوف لها لستة كل واحدة لها تعدل بكمية معينة. فمثلا لو جاك بس للفيلوز يعني لو جاك واحد مثلا بوست ريفراكتيف هايبروبيك ولا مايوبيك تفرق معك وش الاي او اللي بتستعملها له لانها تعدل هذه شيء وهذه شيء. هل بتحط له سفيريك ولا اي سفيريك؟ فهمت علي؟ اذا هو مايوبيك ولا هايبروبيك. طيب فالشيب can be prolate or oblate. Prolate, this is the normal shape of the cornea. It is a prolate. The central is steeper than the periphery. Oblate, the center is flatter than the periphery. So this is the normal. The center is steeper than the periphery, whereas in oblate, let's say this patient post-myopic ablation, the center is flatter than the periphery. So this is oblate cornea. So what is the spherical aberration of this one? Positive or plus or minus? Plus. And this one? ممكن هذه minus ممكن plus. على حسب. بس هذه for sure انها بلس. طيب فهذه بوزيتيف كيو فاليو هذه نيجاتيف كيو فاليو ولكن spherical aberration هنا ممكن بلس ممكن يعني ممكن بوزيتيف ممكن نيجاتيف. بس هنا oblate for sure it is positive. طيب. So we have also hyperprolate cornea after hyperopic ablation, keratoconus, and in some cases of mini monovision when you induce a higher Q value just to give more depth of focus because we said spherical aberration will give you depth of focus. And oblate after myopic ablation like the example just given. So hyperprolate is negative spherical aberration while oblate is positive spherical aberration. This is hyperprolate. This is prolate. This is oblate. Clear? نفس الإكزامبل السنة اللي راحت. طيب. Aberrations. Spherical aberration. Usually we have ocular spherical aberration. It is a sum of the spherical aberrations from four refracting surfaces of the eye: anterior corneal surface, posterior corneal surface, anterior lenticular surface, and posterior lenticular surface. الحين نجي للمثال اللي تو خذيناه. عندك two patients. One is 19-year-old. The other one is 72-year-old. The corneal Q value is minus 0.26 in both patients. So the corneal spherical aberration is plus 0.27. متفقين على هذا الشيء؟ في أحد عنده أي ملاحظة؟ طيب فهي positive spherical aberration. ولكن في اليونج اللينس usually the normal lens will give you minus 0.27 which is a spherical aberration, which is a negative spherical aberration. So the total spherical aberration will be 0. So this patient will have sharp image, but a depth of focus less. However, in elderly 72, usually the lens will change to plus, let's say 0.13, 0.15, 0.2. So he will have what? Positive spherical aberration. Clear? طيب وش نستنتج من هذه الأشياء؟ Up to certain limit in young healthy adults, the human eye handle positive corneal spherical aberration by lenticular, like this 19-year-old boy. And aberration changes with age and increase with age. Also, the positive spherical aberration gives more depth of focus and just to overcome presbyopia partially. Clear? فهمتوها ولا؟ طيب. So this is the spherical aberration, the focus of peripheral rays in front of the central rays. So if it is in front, this is positive spherical aberration. If it is behind, this is negative spherical aberration. So it depends. So it is, if the peripheral is behind, this is negative, or you can say the central in front of the peripheral. لا positive or negative can increase depth of focus, okay? But in our eyes, we can, our brain can tolerate positive أكثر من النيجاتيف، عرفتي؟ فعشان كذا ربي حاط إنها positive لهم، فبتصير positive. بس إذا أنت جيتي مثلا واحد بتحطي له ميني مونوفيجن، في ناس they induce negative just to increase depth of focus على حسب كم الريفراكتيف ايرور اللي انت تبغينه. So the spherical aberration, this is the negative spherical aberration, which is when it is the Q value is less than 0.528, and it is positive spherical aberration when the Q value is larger than minus 0.528. طيب, reference surfaces. Normal corneal shape is aspheric toric ellipsoid. So we have two reference surfaces, toric ellipsoid and sphere, or best fit sphere. The toric ellipsoid, we can use it to see the corneal irregular astigmatism, high order aberration, and also it is used in holiday report map. For the best fit sphere, it is the best reference surface for screening for refractive surgery, to study the shape of the cornea, to study corneal astigmatism, which is low order aberration, study the corneal elevation and localization of the cone. We have two modes, float mode and non-float mode. Usually we are following the float mode. أحد يعرف وش الفرق بينهم؟ في المشين تلقونها كذا float mode و non-float mode. طيب الفلوت mode, you will take in consideration the entire cornea. The non-float mode, it will take in consideration only the apex. So the best fit sphere here, see it is larger than this one. Clear? So we have to follow the float mode. طيب. The parameters that affect reference surface, or how can the machine calculate the reference surface, depends on the average keratometric readings all over the cornea and the diameter of studies zone. So this is the best fit sphere. So if it is irregular cornea, something will lie below the best fit sphere or above best fit sphere. So the curvature map, which one is steeper? Circle. This one or this one? The red, huh? So the steeper, the red, is below best fit sphere. So that's why it is steep. And it is in red. Whereas the flatter cornea is above best fit sphere. This is for curvature map. Okay? But for the elevation, anything above the best fit sphere, it is in red. Whereas anyone or any value below best fit sphere, it is in blue. طيب ليه لخبطونا على كذا؟ واحدة أحمر فوق واحدة أحمر تحت. هم حاطين كلر سكيل بس عشان يخلون حياتنا أسهل، بس ليه لخبطوها زي كذا؟ أي أحمر معناها أنه انتبه، يعني أحمر يا أنها ستيب كورنيا يا أما elevated يا أما thin كورنيا. كلير؟ عشان كذا هم حطوها، فأي شيء أحمر معناها انتبه بس إنه وش قاعد تحسب المشين هذا لازم أنت تفهمه. طيب فهذه أحمر معناها انتبه. طيب and this is for keratoconus. Sometimes you will have value that it is elevated and steep. So the effect of diameter of study zone on best fit sphere. As we mentioned, the shape of the cornea, the normal shape is brulate. So the brulate usually means the center is steeper, so the periphery is flatter. So if let's say we include all the values here, including 41, or here just we include the value 43 and 45. So which one will have lower best fit sphere? Let's say this is 5 millimeter, this is 8 millimeter. 8 millimeter. It will be 42.5 and this is 44. Because here we included the flatter side of the cornea. Clear? So the larger the diameter, the lower best fit sphere. So we have to agree on something, on diameter that we should follow for all patients, because we will follow the normal elevation values. Let's say if it is more than this value, means it is suspicious. More than this value, it's keratoconus. So we have to just standardize our reference surface size, because if we use 6 millimeter, here the value is, this is the same eye, okay? But we change only the size of the best fit sphere. If it is 6 millimeter, it's 20. If it is 8, 23. If it is 12, it is 16. So you have to make it just manual and on 8, okay? So if we increase the size, the best fit sphere will go down and the values will go up. Color scale, as we mentioned, any value with the item with the warm color, it is dangerous. Okay. تبغون نصلي ونرجع؟ طيب يلا. طيب فيما بيتجمعون أحد عنده أي سؤال عن اللي قبل شوي؟ اللي قبل شوي كانت بيزكس، الحين الكلام على البنتكام. سم. مو بشرط.
او خلينا نقول انه اذا كان عندي مثلا الكيو فاليو ماينس 0.26 انه دائما عندي بوزيتيف.
اي
واي ذات؟
لأن بعدين عندك اللينس.
لا انا ليس الرقم يطلع بوزيتيف، احنا نحسبه من ايش بالضبط؟
لأن الزيرو هو ماينس 0.528 حق سفيريكال ابريشن. فهمت علي؟
ايوه، فاحنا ناخذ الفرق يطلع.
اي خلي برجع لها. مشكلة ما ادري وين ذا السلايد. أتوقع أنها الحين بيشبك. أتوقع أنه شبك الحين. No, I want just to show him the Q value. إن شاء الله. هذه فيصل أي شوف هنا الزيرو حق spherical aberration. أوكي واضحة؟ هذا spherical aberration زيرو، ولكن هذا سكيل هذا حق الكيو فاليو، ولكن كسفيريكال ابريشن هنا الزيرو، فهذه كلها بالبلس هذه كلها بالماينس. For me سمي. لا, if you will remove the cataract خلاص regardless of this, but you have to compensate for the cornea. The cornea is static. Yes. Yes. No, this is yes, for sure, yes. For sure, yes. I'm not aware. طيب نبدأ. The 4 refractive maps. Now we will start with the Pentacam reading. So this is the 4 refractive maps of the Pentacam. This is the patient information box. This is detailed display box. This is the curvature map, corneal power map. This is corneal bathymetry or corneal thickness map. This is anterior elevation, posterior elevation map. So we'll start with the detailed display box. This is keratometric value box. When you want to start, you have to start with the name of the patient, laterality, date of examination, then go to the front and back surface of the cornea. So this is the front surface of the cornea, this is the back surface of the cornea. We start with the quality of a specification. If it is okay, means good. If it is in red, means you have to repeat. If it is yellow, in between. So if you will go for something is just for screening and you think the values are good, no need to repeat. But sometimes you have to repeat based on your clinical experience. So this is a topography for with the quality of specification is okay, but however the patient is not looking straight or fixating in the camera, so it gives you false data. So and here the pupil is irregular, it is not circular, so because the eye is deviated. When this is for the same patient when the patient have good fixation. So everything changed. And here, if you can see from this side, it is deviated. So it's very clear that the patient was not concentrating or fixing well. So the Q value, as we mentioned, it measures the corneal shape or the asphericity of the cornea. Usually we take the Q value for 6 millimeter, not 10 millimeter. Here it's 10 millimeter, so you have to ask your technician or the one who's doing the Pentacam to repeat it for 6 millimeter. The normal Q value range between minus 0.26 and minus 0.42. However, others, they consider the normal Q value between 0 and minus 1. For me, I'm not following this school because, you know why? Minus 1 will give you what's spherical aberration? Negative. So for sure it is not true. That's why I'm following the range between minus 0.26 to minus 0.42. Which is more important, the horizontal or the vertical Q value is the vertical, because vertical is will detect the comma in ectasia, like keratoconus. So abnormal Q value result in spherical aberration, as we mentioned. So if it is minus 1 point something or plus something, 1 point something, means the spherical aberration is either too positive or negative. The abnormal Q value may indicate form frost keratoconus. Usually for keratoconus, you will have high minus or plus minus because it is hyperbolate. So the Q value is normally less than minus 0.5, suspicious if it is minus 0.5 to minus 0.55, abnormal if it is more than minus 0.55. That's why when we talk about the spherical aberration, the 0 equals to Q value of minus 0.528 or minus 0.55. That's why here we consider it abnormal, because the spherical aberration will change from positive to negative. Clear? So, and in the machine, you can also, the Pentacam machine, you can get the inferior superior Q value, 6 millimeter, 7 millimeter, 8, 9, 10. The most important 6 millimeter and the vertical. Because if you will go to treat with the refractive surgery, usually, and the pupil size also, usually it is like 6, almost 6.5, like this. This is the horizontal radius of curvature. This is the vertical radius of curvature. This is the flattest K reading within the central 3 millimeter in the anterior surface of the cornea. It is very important in myopic treatment because the K1, the flattest K within central 3 millimeter should not go below 34 diopter after the myopic ablation. So for each 1 diopter of treatment of myopia, it causes a flattening of K readings by 0.8 or 0.75. So if we will, let's say this patient is minus 5. So you will treat or no? If we consider the other parameters are normal, you can treat, yes. Let's say this K readings, and this is one of the examples in the board, I think 2 years ago, they brought 38. Okay, the K1 is 38, and the patient has refractive error something, I think, -6 or -5. What you will do for the patient? So you cannot go for refractive surgery. This is the answer. Okay. So this is the steepest K within central 3 millimeter, and this is important if you will correct the hyperopia. So the hyperopic treatment you should not be more than 48 diopter, and for each 1 diopter of treatment of hyperopia, not myopia, the steepening effect on K readings by 1 to 1.2 diopter. So usually we are calculating it by 1.2 just to be on the safe side. This is the average summation of the K1 and K2. And if you want to take K1 and K2 to be calculated in IOL calculation, if you want, you can take Km and consider it as K1 and K2, and that's it. Okay, the astigmatism. We have anterior corneal astigmatism. This is the anterior corneal astigmatism, and this is the posterior corneal astigmatism. The manifest astigmatism, which is the one done by retinoscope or subjective, it includes the total corneal astigmatism plus lenticular astigmatism. The total corneal astigmatism is the anterior minus the posterior. Why minus? No, why not plus? Why the posterior in minus? أيوة على صوتك. اشرح زيادة اللي فهم يقول، بس الأكثر الناس ما فهموا عليك. اشرحها صح. أي ليه ماينس؟ طيب which one is steeper, anterior or posterior? posterior steeper والفاليو حقته أقل. ليه؟ أيوة كمل. إيه وش فيه الريفراكتيف اندكس؟ طيب اي بس ليه طيب اوكي هذا عشان الماينس اوكي بس ليه صغيره القيمه؟ اي وش فيه؟ اي الديفرنس هاير، فهنا الديفرنس بين البوستيريور والاكيوس از لور طيب والكورنيا از هاير طيب، فعشان كذا تصير القيمه اقل وبالماينس. فما يكفي انك تقول بس ريفراكتيف اندكس، ولازم يعني انه هذا لازم تقول وانه قيمتهم قريبه من بعض، فعشان كذا تصير القيمه حقه الكي ريدنجز قليله مع انها البوستيريور سيرفيس ستيبر ذان الانتيريور سيرفيس. طيب طيب فعشان كذا نحطها بالماينس. الانترنال استجماتيزم is the topographic anterior corneal astigmatism minus the manifest. Usually the normal, the anterior corneal astigmatism is with the rule, and with age it will be converted to against the rule. However, the posterior corneal astigmatism with the rule and no change with the age. Regarding the astigmatism, compare the absolute value of topographic astigmatism with the manifest, the absolute value and the axis. And don't forget the patient might have lenticular astigmatism. Oblique axis and against the rule astigmatism are more worrisome than with the rule astigmatism. طيب, because the normal is with the rule here. The normal is with the rule. If it is against the rule or oblique, it's more worrisome. So the normal difference between the topographic and the manifest should be less than -1 or -1.5, and the angle or the axis is less than 15. This is very important if you will treat, let's say you have a session, excimer session, and you will treat topography guided, and the axis of your refraction is different than the axis of your measured or topographic astigmatism. If it is more than 15, you cannot treat the refractive error. Okay? So you have to compare before you treat the patient if you will go for topo-guided treatment. If it is more than this, it's suspicious and better to be repeated. The total anterior and posterior corneal astigmatism, you can also measure the vector analysis. Vector analysis, if there is a lot of vector analysis calculator on the internet. If you want to measure the astigmatism, the total astigmatism of the cornea, 1.6 and 0.5. So what is the total? You cannot add them together because the axis is different. Okay, so you have to use vector analysis calculator on the internet. So I calculated on the internet and it gives me the total is -1.11 at 0.05. So axis is different and the amount is different. The net amount is different. Clear? Because the axis is not the same. If it is the same, you can just add them together and that's it. So the axis of flat K of front surface of the corneal astigmatism, it can, by the machine, sometimes they will change it in the exam. So they will change it to steep. So you have to concentrate. If it is in red and here mentioned steep, means this is the steep axis, not the flat axis. Oblique corneal astigmatism, it is normal if it is less than or equal to 2 or 3. If it is any astigmatism higher than 6 is abnormal, regardless of the type. The causes of disparity between tomographic and manifest astigmatism, so the refraction is totally different than the tomographic or Pentacam. It can be related to misalignment, cornea-related causes like corneal opacity, irregularity, hot spot syndrome, tear film disturbance, lens-related causes, lenticular, and IOL tilt. In the oral exam, usually they will give you different axes and they will ask you what could be the cause, what you will check for. Okay, and if you the Pentacam is not that accurate in detecting the axis of the astigmatism. Orbiscan is better. طيب. هذه جاوبناها, which is surface steeper is the posterior. طيب. So this is the flattest K, and this also we answer it. طيب. So now we will move to bathymetry. The Pentacam, it calculates the bathymetry of the cornea from limbus to limbus because it is tomography with an accuracy of plus minus 5 microns. So this is the center of the pupil. This is the center of the cornea. So center of the cornea is which axis? Optical. So it is the optical axis. So how to calculate angle kappa? What is angle kappa? When the visual axis? How to calculate angle kappa in this machine? It's a presumption, but we cannot calculate because it is just tomography, not topography. No, there is no Placido disc. Okay, so usually we will come to it, but the Pentacam cannot measure the angle kappa accurately. Okay, that's why in Serras, Galilei, they added Placido disc. This is the pupil center location, and the visual axis location or the angle kappa, it is pupil center plus brachyapex. Usually the brachyapex is the geometric center of the cornea, so it is 0. So just divide the numbers here by 2. This is the angle kappa. If it is more than 0.1 millimeter or more than 5 degree, this is suspicious or large angle kappa. And some will say 0.2. Central corneal thickness. This is the central corneal thickness, 575. This is the thinnest location. Thinnest location, you have to comment on 4 things. هذه في الاختبار لا حفظ، يعني على طول طق 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 طق، ما تفكر فيها. المفروض هذه درجات جتك لازم تاخذها. طيب، value of thinnest location، كمل value، compare both eyes، difference between brachyapex and thinnest location here, and relationship between the brachyapex and thinnest location, the vertical coordinate. طيب. So we'll start with the value of thinnest location. If it is more than 500, it is normal. If it is less than 470, this is abnormal. Compare both eyes. If the difference is between both eyes more than 30 microns, this is abnormal. So you have to, if you want to interpret any Pentacam, you should examine both eyes in the exam. They will give you 1. So you have to ask about the fellow eye. The difference between brachyapex and thinnest location. If it is less than 10 microns, it is normal. If it is more than 10 microns, this is suspicious. Relationship between brachyapex and thinnest location, the vertical coordinate, and this was answered before we start even. So abnormal if it is more than -1 millimeter. So Kmax. What is the difference between K2 and Kmax? K2 is the steepest K within central 3 millimeter, whereas Kmax is the central is the steepest K all over the cornea, entire cornea. Kmax you have to comment on 3 things. هذه برضو نفس الشيء، درجات وجتك. Value of Kmax, compare both eyes, difference between Kmax and K2, the steepest K. So the value of Kmax, if it is, it should be less than 47.2. This is the normal. If it is abnormal, if it is more than 50 diopter. Compare both eyes. It should be less than 1.9 or 2. And the difference between Kmax and K2 should be less than 1 diopter. So this is a summary for the thinnest location and Kmax. This is white to white, and it is only in the new Pentacam HR and the newer versions. The angle, smallest angle of size in horizontal meridian, it is abnormal if it is less than, this is for glaucoma, 22.4 degree, and the chamber volume, it is abnormal if it is less than 84 millimeter. AC depth. The AC depth we can have end or ext. Ends mean internally, measured from the endothelium. And usually we are measuring it from endothelium. Okay? For phakic IOL. But for IOL master or the biometry, usually the machines for biometry will measure it from X. So it will be 3.14 plus the brachyapex or thinnest location. This is for the biometry. But here, for our phakic IOLs, we will use end, not external. So you have to concentrate on this one. It's tricky, but you should concentrate for it. Pupil diameter, this scotopic pupil diameter. And for me, I don't rely on this pupil diameter. For me, the other machines is much better because it will give you the scotopic, mesopic, and photopic pupil diameter for refractive surgeries. This is the IOB adjustment based on CCT. This is the lens thickness. When the pupil is dilated, usually the machine will calculate the lens thickness. Corneal power map. We have different corneal power map. So we will finish the bathymetry. Now we'll start with the power map. So this is the axial sagittal curvature map. This map does not represent the optical power of the cornea, despite having diopters. فهمتوا وش المكتوب ولا ما حد فهم؟ وش معناها؟ لا باكيمتري لا الاوبتيكال باور اوف ذا كورنيا هذه ما لها علاقه فيها. هذه تحسب لك الانتيريور وكيف حسبت الانتيريور بعد شوي بنجي لها. طيب بس ما it is not a real number يعني. The optical power depends on the curvature of the cornea but requires Snellen law. عاد Snellen law ما قاعد اشرح لكم اوبتكس اقروها لانها يبغى لها تحسبها كيف كل منطقه كم تعكس على الماكله على الفوتوريسبتورز. طيب فريفراكشن based on the refractive index difference between the surfaces. طيب فالاكزيال versus tangential we have curvature maps, we have axial, tangential. So the axial we have video keratoscopic reference axis, and let's say we will measure this area, this point. This is the area of this is the axial radius of curvature. So we are now measuring the axial, not tangential. So this is the axial, and usually this reference is 42.1875. This is pre-selected by the machine, but then the axial they will measure the radius of curvature toward this reference axis. So based on that, they will measure the best fit sphere for our points. The tangential, no, it will not rely on this reference axis. It will measure each point differently. So the peripheral cornea and tangential will become flatter because the radius of curvature will become longer or larger. So this is the sagittal, also known as axial. It is the default, and usually in the machines you will see only this one, unless you ask for tangential. So the tangential is a better tool to identify the keratoconus cone and irregular astigmatism. So if you have irregular astigmatism, ask for tangential. But tangential is too noisy. Sometimes it will exaggerate everything. So if you are comfortable with the sagittal, go with sagittal. The tangential suggests that it is more sensitive for early keratoconus and progression, less sensitive to eye misalignment. So if the patient is uncooperative, the tangential is much better. But you have to follow the patient with tangential. Disadvantage is low measurement repeatability due to higher sensitivity to noise from tear film irregularity. So if the patient has dryness and incooperative, you cannot go for tangential. But if there is no dryness, you can go for tangential. So, and this is the difference. So the apex K readings or the central K readings in tangential is higher. The cone location is more central in the tangential. Sensitivity to curvature changes or progression or the cone and keratoconus is higher in tangential. Sensitivity to tear film irregularity is higher. Sensitivity to eye misalignment is lower in tangential. And this same eye with tangential and axial sagittal curvature. Okay, we have another power map. It is true net power. The true net power, you have to know only that it measures the anterior and posterior. But if you want to use true net power for IOL calculation, you have to use a formula that made to be used for true net power, like Holiday 2. Because this is modified value. So if you modify this value, then modify it by another formula, you will have double correction. So the true net power usually will give you less K readings. It includes the anterior and posterior. So for sure the posterior is negative, so it will give you less. But you have to select the formula very carefully. The refractive power map, this is usually the K readings will be flatter in the center and steeper in the periphery. And this is only used after refractive surgery if you want to assess the quality of vision of the patient. Okay, so let us start with the interpretation. So this is, you have to check the eye, it is OD or OS, and the temporal side of the cornea, nasal side of the cornea, the corneal diameter included. Sometimes you have to include 8, and sometimes you have to include the 12. When we should include the 12? If you are looking for peripheral part of the cornea, like pellucid. So this is for same eye with different corneal diameter included in the study. So this is 12 and this is 8. And here the circle is 3, 5, 7. Here is the 3, 5, 7, 9, and 12. Clear? And this is the color scale. You can change the color scale the way you want. And in topography, each step varies from 2 diopter to 10 diopter. Each step can be adjusted. So each step can be 0.5 diopter. And this is for the same eye with different color scale. You can you can say this is a very advanced keratoconus, and you can say this is moderate keratoconus, based on the color scale. So you have to make the color scale standardized for all patients. So you will be familiar with the colors and you will diagnose the patient very fast. This is extrapolated data when you have dots or white sector. So it means poor quality of this area. So the more extrapolated data, the less reliable test you have. And we have to make sure that the 8 millimeter, the central 8 millimeter, should be free of extrapolated data to have a reliable data. This is the pupil center. This is the circles. Okay. So this is the pupil of the patient. For me, usually I'm doing the Pentacam before dilation, not after dilation, because the AC depth will be changed and sometimes the patient cannot fix well after dilation. This is the K readings, keratometric readings, and you have to know that usually the cornea will have steeper cornea because it's prolate shape, steeper cornea in the center and flatter in the periphery. And usually the nasal side is flatter than the temporal side. So if they remove the T and N and they ask you where is the nasal, just the one with lower number is the nasal side. If the difference between the central and peripheral more than 4 diopters, this ectasia should be rolled out. So how to comment on the keratometric readings here? 5 أشياء ما فيها كلام، لازم تقولها كلها. Value of K readings, asymmetry, superior inferior or inferior superior, skewing, astigmatic pattern, and enantiomorphism. خلوني أسألكم سؤال، وش معنى irregular astigmatism? Define irregular astigmatism. غير انك تقول لي ان الاكسس 90 ديجري يا بارت، لا ما ابغى هذا، ابغى شيء ثاني. كيف تعرف بالبنتكام ان بدون ريفراكشن this is irregular astigmatism؟ skewed any skewed خلاص irregular. اي واحده لو 50 degrees خلاص معناها هذه irregular astigmatism. كيف؟ لها شرط skewed. أي skewed يعني الأنجل more than 21 خلاص this is skewed؟ لا. يكمل ستيفنينج. أي. طيب. اوكي هذه واحده ان الديسباريتي، هذه واحده عشان تقول انها الريجولار كورنيا. فلما يجي الاوبتومترست يسوي ريفراكشن يا يختار اللي تحت او اللي فوق، صح؟ بس سكيوينج كيف؟ سكيوينج هي الشيء الثاني عشان تعرف ان عنده الريجولار استجماتيزم. بس كيف تقول ان هذه سكيوينج؟ يعني اي سكيوينج خلاص سكيوينج. مين اللي قال وشو؟ اي لازم الاستجماتيزم تشيك عليها كم، لازم more than 1.5. اذا هي مثلا 0.8 الاستجماتيزم and there is skewing, this is not significant skewing. طيب how to know if it is irregular astigmatism, skewing, inferior superior disparity or irregular pattern? So irregular astigmatism. طيب clear؟ يعني لو بختبركم أنا في البنتكام بقول لك وش معنى irregular astigmatism. أول سؤال، ما أبغاك تقرأ البنتكام، أبغاك تعلمني وش معنى irregular astigmatism. طيب keratometric readings. So the value of K readings, if it is more than 47.2, this is abnormal. The corneal irregularity based on the axial sagittal map. ما هو tangential axial sagittal map, inferior superior asymmetry, سواء superior inferior or inferior superior. So this is, we call it asymmetrical bow tie. So نجي الحين الموضوع كيف تحسب الانفيريور superior asymmetry. Usually we take 2 points and that's it. But ideally, if they ask you ideally in the exam, you should take 5 points superiorly and 5 points inferiorly, 30 degrees apart. This is ideal, this is for research. But in the clinic, you cannot go with 5 points and compare each. Okay, but if they ask you in the exam, you have to mention that the difference of corneal power comparing 5 points, 30 degree apart, 3 to 5 millimeter inferior to the center to superior, or superior to inferior. طيب, skewed radial axis value or skewed or lazy bow tie, it measures the gradient power along the steep axis. It measures the angle between the more curved superiorly with the more curved inferiorly. And usually the course of keratoconus, the superior steepening will bend and the inferior will become steeper and bend. But the superior usually will bend. So the asymmetry, inferior superior or superior inferior. فهذه وش نعتبرها؟ أبغى واحد R1. أبغى R1. طيب هذه inferior superior ولا superior inferior؟ هنا حددت لك 51 و 48. هذه superior inferior صح؟ طيب يعني كمل، هل هي significant ولا لا؟ حاط لك أنا كم significant كم هنا. إذا superior larger than inferior، هذه superior larger صح؟ طيب فهنا إذا superior larger it should be more than 2.5. طيب إذا inferior larger than superior, normally it is less than 1.2. If it is more than 1.2 you have to suspicious, more than 1.5 خلاص this is abnormal. Okay, so it depends which one is the larger amount or higher K readings. So this is the skewing. How to calculate the skewing? Which angle? طيب خلونا نقول هذه A B C D. أي angle؟ A B C D. كيف؟ A and D. لا هي لا يمكن تصير A and D، يا AC يا BD، لا يمكن، لأن هذه الأنجل هي نفسها هذه وهذه هي نفسها هذه، فهذه A وهذه B وهذه C وهذه D، فهذول زي بعض. A و C ولا B و D؟ التصويت من اللي يقول A and C؟ طيب واللي يقول B and D؟ والله الأغلبية صراحة صح، اللي هي هذه. طيب فهي A and C. طيب if the angle is more than 21 and the astigmatism is greater than 1.5. If it is the astigmatism is less than 1.5 ما يعتبر skewing. طيب في references they will mention that if the astigmatism more than 1. But if they give you astigmatism 0.8 with the skewing, this is not skewing, not positive skewing or significant. So it quantify the irregular astigmatism and it can be false positive in 0.05% of normal population. But it is not an early sign of keratoconus. Why? تونا قايلينها لأن الكيراتوكونس لما تبدأ بعدين يصير البندنج يعني with time السوبيريور part will bend الانفيريور will steep and bend but it will take time. This is not an early sign of ectasia. Usually if you want to detect early ectasia you will go for the posterior elevation. Okay. So this is the skewing. If you want to calculate it يلا خلنا نحسبها مرة ثانية. هذه ولا هذه ولا هذه ولا هذه. هذه A B C D. يا شباب حاط لكم هنا العلامة يعني أوضح من كذا ما فيه. هذه وهذه يعني حاط لكم هنا والله. طيب فالاستجماتيك باترن في عندنا astigmatic pattern. This is for the axial not tangential. Okay, the astigmatic pattern asymmetry that depends on the amount of steepening and the axis of orientation if there is skewing or no. So it can be the most suspicious is asymmetrical bow tie, inferior superior asymmetrical bow tie, and it's highlighted here with the red color. And the abnormal pattern is the butterfly claw and junctional. طيب نجي الحين example. So the patterns here you have to memorize them and by heart because in the exam you will mention that this is oval, this is this is symmetrical bow tie. This is for description in the exam. So you have to know them because you will describe the pattern based on the this image. Okay. طيب يلا. Name the astigmatic pattern. أيوة. Inferior steepening. طيب. Mention 3 causes that can cause this astigmatism. كذا في الإكزام بيجيبوا لكم. أيوة. Okay. والله هي 3 بس خلوها 5. سكار هذه مهمة. وش بعد؟ شو أقدر أحط لكم 3 وخلاص بعدين في الاختبار بيقولوا لكم mention 5 فبتتورطون فيها بعدين. طيب ممكن decenter ablation ممكن أشياء كثيرة. طيب decenter ablation ممكن يصير إنه هنا سووا الابليشن وممكن إنه أصلاً هو induce hyperopia وصار decenter. طيب type of aberration كوما clear كلنا يتفق إنه كوما. طيب الكوما نوعين في vertical وفي horizontal كوما. vertical كوما فخلاص بدون الزيرنيكي أنا الزيرنيكي ما حطيتها في البرزنتيشن لأن من هنا خلاص أنتم تقدرون تعرفون ولكن بعض الأحيان بتصير متلخبطة مرة الريجولار استجماتيزم فتحتاج إنك تفتح الزيرنيكي ماب عشان تعرف what type of high order aberration. بس هنا clear it is coma. طيب فكوما is it clinically or visually significant? Yes. So this patient will come to you for sure and ask for treatment. And is it corrected with spectacles or soft contact lens? No. How to correct it? How to approach this patient? Hard contact lens is the first option. طيب بس surgery تخليها في الأخير. طيب طبعا وتشوف هل هي كيراتوكونس، ما هي كيراتوكونس، هل هي descentered ablation، هل في سكار، على حسب التريتمنت يختلف على الكوز. ف you have to know the causes, then based on the causes you have to treat the patient. طيب another example. Central flattening, mention 2 causes. myopic correction وإيش؟ سكار. طيب خلصنا. طيب type of aberration. spherical aberration. spherical aberration. ليه spherical aberration؟ ليه spherical aberration؟ لا ما هو ثكر، ستيبر قصدك، ستيبر. اي فهذا البيشنت تتوقع انه بيجيك ولا ما راح يجيك يشتكي؟ كيف؟ اي نايت كومبلين. فيعتمد على ايش؟ يعتمد على البيبل سايز حقه، بس غالبا هي والكومبلين. طيب اذا البيبل سايز حقه كبير اكيد انها بتدخل هذه المنطقه اللي فوق فبيبدا يشتكي منها. كلير؟ طيب باكيمتري. خلاص we finished the curvature. Bachimetry. This is the pupil center here and here. So this is the sign of pupil center. This is the thinnest location. Thinnest location you have to comment on the Y coordinate corresponding elevation. This is very important. السنة الجاية كاني قدمتها بحطها بالأحمر. Asymmetry and shape. طيب value of thinnest location of bachimetry is not included in assessment because. فهنا لو تشوفون دقيقة أي ممكن إنك أنت تلقى مثلا زي هذا thinnest 573 but here we don't have 573. So you cannot depends on the map to know the value of the thinnest location. لأن sometimes it's not included. It is here. So here, if we take one large map from the machine, you will get 453. Whereas if you take the 4 refractive maps, the regular one or the default, you will get only 455. So you have to depend on this box. So the Y coordinate, as we mentioned before, you have to check it, and the corresponding area of cone. So let's say this is the thinnest area, okay? And here is the corresponding elevation here, because it is circle, right? We agree here. This is circle, so here is the thinnest location, and here is the thinnest location. Clear? طيب عشان تعرفون بس كيف corresponding area. So is it significant? No, but here it is significant. It is here, but it's significant. Clear? فيو have to correlate it. هذه من أهم الأشياء في الريدنج اوف بنتكام. يعني لو قلت كل شيء وما قلت هذه الكورسبوندينج اريا اوف elevation معناها راح عليك جزء كبير. هذه أهم شيء تقوله. طيب superior inferior difference, the difference between here and there. Compare central 5 millimeter, sorry. If the difference less than 30, this is normal. If it is more than 30, this is suspicious. Why it is important? Let's say in the patient لابسه contact lens أو لابس contact lens, hard contact lens. تبغى تعرف هل effect من contact lens ولا إنه ectasia. If the difference is more than 30, usually it is not related to the contact lens. It can be partially related to the contact lens, but not fully. So, but however, you will ask the patient to come again and reevaluate and assess. But sometimes from the beginning, the difference is 50 or 60, you know that it is not just related to the contact lens, most likely. So the shape of the bachimetry, this is dome shape, this is bell shape here. So it is the hallmark of BMD. So we finished with the bachimetry map, elevation map, we have reference body shape. We have toric ellipsoid fixed, and spear. You can use anyone, but some of the reference bodies, body shape, like toric ellipsoid, will mask the cone. بمعنى انك اذا انت تبغى تسوي الحالات كلها وما تنتبه للكيراتوكونس or you will not screen for keratoconus وتبغى تسوي بس عمليه، حط toric ellipsoid، ما انت بشايف شيء. طيب إلا إذا أنت صرت حذر مرة. أفضل شيء البست فيت سفير to screen for ectasia and refractive surgery and to localize the cone to study the shape of the cornea and low order aberration, corneal elevation. The toric ellipsoid is good only for the irregular astigmatism, high order aberration, and it is used in holiday report. It masks the cone. So usually we are using best fit sphere, and even in the exam they will bring best fit sphere. If they brought or bring the best fit toric ellipsoid, you can ask for best fit sphere. Okay, the values you are measuring or evaluating the patient based on, it's different between sphere and toric ellipsoid. And here is the diameter. This is on auto. You should put it in manual. Why? And manual and select 8 mm. قلناها ليه تبغى 8 mm؟ كيف؟ لا كيف؟ وش قلت؟ اي اذا حطيته اوتو. طيب اذا حطيته اوتو بعض الاحيان بيطلع لك 7 بعض الاحيان 9، فالفاليوز اللي بتطلع لك مختلفه. طيب فما تقدر تقول والله هذا elevated، ما تقدر. طيب فلازم تحطها 8 وخلاص تمشي على الفاليوز اللي بناخذها. اما انك تحطها كبيره مره تطلع الفاليوز بدل ما انها 17 تطلع 20، فبتقول اوه هذا على طول كيراتوكونس. Yes, it will make it smaller. فعلى حسب، إذا هو قدر ياخذ 9 بيحط لك 9، إذا قدر ياخذ 7 خلاص بيحط لك 7، على حسب مزاج الماشين. بس النورمال فاليوز اللي عندك كلها على 8، فخلاص امش على 8. فلازم تغيرها تحطها على مانيوال و8، ولازم تشيك في كل فحص هل هي 8 ولا ما هي 8، وبنجي عليها. طيب طيب الماب elevation interpretation, cone location, shape of elevated area, value of elevation. Cone location, is it central, paracentral or peripheral? And it is very important يعني if you will diagnose a patient with the pellucid or keratoconus, and if you will go for rings. So the cone location, shape of the elevated area, is it regular pattern or irregular? Central island. Central island is it's more worrisome than the others. If you have symmetrical hourglass, and usually the hourglass you will have it if it is the astigmatism is 1 diopter or more. Irregular pattern like tongue-like extension, skewed hourglass, non-specific irregular pattern. But all patterns not considered as abnormal unless the value is abnormal. That's why we have to select 8 mm to know the value if it is abnormal or normal. So this is isolated. So how to comment on this one? We can say significant because the value is very high, significant, positive, isolated, or central isolated island. Okay, so we have to mention, is it significant or not significant? And where is the location? Is it central, paracentral, peripheral? This is hourglass appearance, if it is skewed or no. And if they ask you about the amount of astigmatism, it should be 1 diopter or more for this patient. And here the diameter is 8. Okay, here is the diameter is 8. وين؟ لا هذه بس حاط لك اياها، بس هذه ما هو في الحسابات، هذه بس طلع لك الشكل، بس الحسابات حاسبها هو على 8، خذ الداتا حقت ال8 بس هذا الحجم تقدر تحطها 12 عادي على راحتك، بس الداتا اللي خذاها 8. ناظر حتى هنا يحط لك اياها مع انها يعني اكزيال، حاط لك اياها 9، عرفت؟ فما له علاقه. طيب فالشيب اوف elevated. طيب هنا عندنا بس عشان نربط الاكزيال بالelevation. Here is the elevation, here is the axial. This is the flat axis, right? But on the elevation it is in plus. It is above best fit sphere. فهمتوها؟ لا ما هو steep. لا. This is the flat axis. Flat axis usually for the axial خلاص neglect the elevation. For the axial, the flat axis will be above or below best fit sphere? Above. And for the elevation, if it is plus number means above. صح؟ فهمتوها ولا لا؟ ترى هذه نفس العين. هذا هنا الفلات اكسس صح؟ الفلات اكسس if we talk about the curvature map, if we will talk about curvature map الحين concentrate على curvature map. الcurvature map if it is above best fit sphere this is flat or steep? لا 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 لا. دقيقة برجعكم. والله هذه وين الفلات وين الستيب؟ الريد ستيب صح؟ فمعناها below البيست فيت سفير صح؟ وتذكروا هذولي. فهذه below البيست فيت سفير. ولكن الاليفيشن أي شيء above the best fit sphere this is elevated. Anything below the best fit sphere this is depressed area or depression. Clear؟ مع أن الألوان يختلفون. ليه قلنا الألوان يختلفون؟ عشان هذه. Clear؟ طيب نرجع الحين. يوم قربنا نخلص طيب هذه. فهذه الحين فلات. الفلات وين بتصير؟ above صح؟ طيب والإليفيشن also above. فهذا الأزرق مع هذا الأزرق هو اللي هنا. ولكن الفاليوز هنا لاحظوا أنها أقل من هنا. والفاليوز هنا أعلى من هنا. لأن هذا إليفيشن وهذا أي. وحطوا لكم الألوان عشان بس تفهمونها بس بدون ما تعرفون هذه بدون ما تدوشوا مخكم. طيب الستيب هنا الستيب فهذا بيصير above ولا below البست فيت سفير؟ below. وهنا في الاليفيشن هذا below. فعشان كذا الأرقام هنا بالماينس. شوفوا minus 35 minus 7 minus 11. clear؟ Tongue-like extension, it's worrisome, irregular pattern, the value of elevation. طيب هنا ال value of elevation هذه الاختبار. طيب ال value of elevation هذه الاستدي حقت أمبروسيو. elevation front thinnest لل anterior is 8. طيب for the back is 18. This is for myopia. الحين بنجيها. أي هذا في الميوبيا. طيب هذا اللي حاط لك هو الستاندرد فاليوز فور everything اذا انت تبغى تعرف. وسوى الاستدي على 431. اي واحد منكم يبغى يسويها على 2000 3000 يسوي. طيب والاستدي حقته ما هو على النورم على البوبوليشن حقنا فتقدرون انتم تسوون النورمال فاليوز. طيب elevation maps فعندنا الفاليو اوف elevation البوستيريور elevation if it is less than or equal to 17 this is normal. If it is more than 20 this is abnormal. Should be in plus here plus not minus. And this is for myopic patients 8 millimeter diameter not 9 not 7 best fit sphere not pteric ellipsoid at thinnest location. This is at thinnest location. So here at thinnest we have the elevation front at apex or 4 millimeter, maximum 4 millimeter. So we will follow the thinnest. It's more significant. For the anterior elevation, it is 8. So 17 and 8. Clear? طيب. Topometric indices. And I think there's a lot of studies studying the indices, and they try just to make it more significant. So the index of height of decentration, IHD and ICV, are the most sensitive indices to detect keratoconus. طيب بيلين أمبروسيو خلصنا. طيب بيلين أمبروسيو قلنا فيه توريك إليبسويد، فيه بيست فيتسفير، فيه enhanced ectasia display. enhanced ectasia display هذه اسمها بيلين أمبروسيو أو bad display. We have two parts of it: enhanced elevation data and bachymetric distribution data. طيب هذه عرفتوها؟ إذا ما فهمتوها قولوا لي، لأن ما نقدر نشرح بيلين. كلير؟ طيب فالآن عندنا هذه الكورنيا، لنفرض أن في النص عندنا 55 and in the periphery is 41. If we measure the best fit sphere, طيب best fit sphere will be 45.25. So this area, the 55, will be elevated by 9.75. Okay? From this best fit sphere, the orange one. Although the real elevation is 12, صح? بين 43 or 55. But because we included the periphery, so that the elevation is only 9.75. طيب هذا وش بيسوي لنا؟ وش المشكلة؟ It will mask everything. So لما جاء الحين بيلين وأمبروسيو قالوا أوكي الماشين will exclude central 3.5 or 3 or 4, depends on the algorithm. So for each patient they will exclude 3 or 3.5 or 4, depends on the Pentacam for each patient. So they will exclude optical zone of 3.5, let's say, millimeter, centered on the thinnest point of the cornea, because they know that most likely the cone will be on the thinnest part of the cornea. Then best fit sphere will be recalculated on the central 8 millimeter zone. طيب خلونا نسويها. لنفرض ان الحين شلنا ال 55. اوكي هذا السنترال 3.5 millimeter. We exclude the central 3.5 millimeter or 3 millimeter, it is, which is 55. So now we have 41, 44, 42, 43. We will recalculate now best fit sphere. So it will be 42. Now we will add again the cone, the value of the cone. So the cone now will be elevated from best fit sphere, which is 42, by 13 diopter. طيب حل ممتاز، ولكن في مشكلة. وش هي؟ اي بس في شيء برضو ان الحين الديفرنس صار 13 but in reality is كم؟ 12. اي فبعض الاحيان بيقول لك ان ترى فيه abnormal values وهي normal. طيب فهذه مشكلته، انه مع انه كذا انت مبسوط انك انت خلاص صرت في السيف سايد، بس بعض الاحيان you will exclude a lot of patients. But usually the sensitivity and specificity is good. طيب. Yes. Yes. So, and this is enhanced elevation data, and this is bachymetric distribution data. Clear? طيب. So this is the baseline of the patient. Best fit sphere on 8 millimeter. حتى لو في المابز اللي قبل أنت مختارها أوتو، هنا ما عنده أوتو، هنا بيخليها 8 من نفسه. هم عارفين إن أوتو غلط، فيحطها هو 8 من نفسه. طيب here after enhancement, after they exclude the central 3 or 3.5 or 4 millimeter, and here is the difference. It is color coded and you can see it. The sensitivity is 96% and specificity is 98%. Clear? طيب now we will go to the bachymetric. So now the bachymetric distribution, the front and back elevation, the thinnest point. This is on the thinnest point. So if you don't want to check on the 4 refractive maps the elevation and the thinnest point on the map, sometimes you will not see the number of the thinnest location. So you can just see it from here. But they change the value with the upgrade. They make the front elevation 7 is normal. If it is more than 7, it's abnormal. And 13 for the back. Okay? So they lower the values. This is the update from them based on their studies. So up to you. You want to follow this one or you want to calculate yourself. Chamber analysis and progression index. It will show you the corneal bachymetric changes relative to the data from normal population based on the bachymetric map, not elevation. So we have ART. ART stands for Ambrosio relational thickness. Here we have the average. If it is less than 1.2, this is normal. And we have ART max. ART max, if it is less than 339, this is abnormal. Less than is abnormal. And usually it will be highlighted for you with yellow or red. However, the ART average, you have to calculate it yourself. So you have to take the thinnest point here and divide it by BBI max. And if it is less than 424, this is abnormal. Okay. And this is thickness profile, thickness data profile. It has higher accuracy than single point CCT, starting from thinnest point and its location, then calculate the annular thickness. We have 2 graphs, the corneal thickness spatial profile graph and percentage thickness increase. In this graph, you have to mention the deviation, if it is the deviation of the red line, if it is less, before the 6 millimeter or before 4 millimeter, and the shape of this curve, and the zone of 6 millimeter, if it is in between the standard deviation. So, and corneal thickness spatial profile in BMD, this is the BMD example. Usually BMD, the thickness in the periphery will be less, okay, if you go to the periphery. This is an example of Fuchs when the central thickness is 700 and also the peripheral is 700. Percentage thickness increase. This is for from the central thinnest central corneal point to the periphery. And lastly, this is deviation or normality of corneal front elevation. This is for the back elevation. And this is the deviation of normality of corneal backy progression. This is for the thinnest point. This is for ART max. And this is for the standard deviation from overall or cumulative map of all parameters in the bachymetric Billen-Ambrosio data. So if it is less than 1.6, this is normal. If it is more than 2.1, it will be highlighted as red color. And sensitivity is 99, specificity is 100 as per their studies. And if we change the 1.6 to 1.5, as Dr. Ahad mentioned, that the sensitivity and specificity will be changed. And we have to correlate also, and they will correlate in the following years, the number of this bad display, the cumulative data, with the age of the patient. So this is the normal, 1.6 is normal for age 30 or 31. But if it is less, you have to multiply it by 0.35, or add 0.3 or 0.25 based on the age. You have to add it to this value, okay, and check if it is normal or no. And you can compare both 2 exams, and thank you. كان ما شرحت شيء. كان ما شرحت ولا شيء. طيب تبغون اكزامبلز ولا على راحتكم؟ الاكزامبلز هي اللي بتجيكم يعني غالبا نفس الفكره، ما راح تغير شيء. اوكي، بس ابغى بسرعه احد يجاوبها، يعني مو بنقعد نختار 10 دقائق عشان احد يجاوب. ابغى احد من الريزدنت، وابغى ما يصير R4. اوكي طيب يلا الفيرست كيس. يلا عبد الله. خلنا نعطيك مايك، وش رايك؟
So first we have to check the patient and the date. After that, this is the right eye. We can see I will start with the numbers first, the left. So the case, it's 43, 45, still it's within normal, less than 47. And the astigmatism 2.6. The quality of specification is normal. Q value is normal also. The corneal back is still good, and also the quality of specification and the Q value. Then I will go the pachymetry. The pachy apex is 513. Good thickness, and then the Kmax, there is no difference between the Kmax and the steep K there. The decentration in the y-axis in the thinnest location is 0, so this is normal. Then I will go to the axial or sagittal curvature map. First, the shape, it looks normal, symmetrical both eye. The shape looks normal, it looks symmetric. Then I will go to the corneal thickness. The corneal thickness is round, it looks, the thinnest location is 513. It's in the center, it's not displaced. Then the elevation maps, the front is 8 millimeter, and the shape is hourglass, and this looks symmetric as well. And the back elevation is also hourglass, and the back elevation, the thinnest there within 3 millimeter is +2, so it's still less within normal. So if the question looking for refractive surgery, first I have to see the other eye and ask the age and also the family history. But if this for this, and also have to know what is the refractive power.
Refraction.
The refraction.
طيب تقريبا غطيت كل شيء، بس لنفرض اني انا ارجعك على الثينست لوكيشن هنا. طيب thinnest location، وش الاشياء اللي بتعلق عليها في thinnest location؟
So the thinnest location decentration.
الواي coordinate.
الواي coordinate.
Okay.
And then
the value.
The value.
هذا اللي قلتها، باقي اشياء.
The location to the where is the thinnest location in the maps?
اللوكيشن بعد شوي بنجيها، بس هنا نتكلم عنها.
So compare between two eyes.
ايوه، كم لازم الفرق؟ اقل
25 or
30. طيب وش بعد؟ باك ايبكس، لازم تقارنها بالباك ايبكس. كم لازم الفرق؟ اقل من كم؟
10
تقريبا. طيب الكي ماكس، وش بالاشياء اللي بتعلقها على الكي ماكس؟
كي ماكس
الفاليو.
the value.
وش بعد؟
both the other eye.
other eye.
It should
كمل
be
لازم اي
less than 1.
1.9 او 2
1.9.
تقريبا اي. وش بعد؟ والثالثة
Compare it to the K2.
K2.
Yeah.
Yes.
The K2 I mentioned for the other eye. Less than 1.
اوكي طيب كمل.
So here Belen and Brescio map. Yeah, they did proof. It looks normal. So first the maps in the left it looks green. So there is no big difference between the.
طيب do you think it is normal?
Yes.
Okay. So you will go for surgery for this patient.
Yes.
Okay. So this is normal topography. Okay. بيسألك مثلا بيقول لك what type of astigmatism is this one? Is it regular or irregular? And what type of astigmatism?
Regular astigmatism, and it is. Okay. With the rule.
With the roll? كيف تعرف انها with the roll؟
The steep is vertical, it's 90.
اي. في with the roll في against the roll في oblique.
يعني almost 90.
لا لأن هنا ناظر 27 تقريبا الانجل 27 فخلاص انت داخل في اوبليك. طيب
What is the cut? يعني they say 30s and more is oblique.
لا 15 or 20. What do you think دكتور؟ Yeah 15. أنا for me I'm following 15 صراحة. يعني maximum 20 maximum.
Optometry they say I think 13 if I'm not mistaken.
30 or 13?
13.
13. 30.
30.
اي
In basic science course.
طيب another patient. طيب بس عشان نختصر هذه احد ثاني غير عبد الله. R4 هذا اختباركم. يلا.
اوكي.
طيب خليني اقول لك شيء، ابى اسالك بس بعض الاسئله. What type of astigmatism?
Regular astigmatism.
Regular astigmatism.
Yes.
طيب is it compatible with the refraction or no? شوف الريفراكشن هنا حاط لك اياه.
Yes.
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 طيب is it keratoconus or no? Yes or no?
I didn't see any signs. No.
No. طيب ممكن form frost keratoconus؟
Could be.
كيف تعرف؟
Either by the other eye.
other eye. اسأل عن other eye.
Yes.
ليه لازم تسأل عن other eye هذه؟ لأن الثيكنس عندها أو عنده
Borderline.
اي شوي عرفت؟ فأنت لازم تصير في بالك إن I have to see the other eye also.
Yes.
طيب خليني أعطيك example ثاني. فهنا عنده هذا وتسأل عن البلن طبعا. طيب فالبلن هنا نورمال. خليني أعطيك هذه. What do you think about this one? minus 0.75, minus 0.5, axis 165, 20/20 vision, looking for refractive surgery. Normal or abnormal? Or suspicious? Or ectasia?
This is very suspicious. Yeah.
Why?
عنده thin cornea.
أيوة. كمل. متى بتقول thin؟ تقول abnormally thin.
470 is the.
Okay, excellent. أيوة.
Also.
طيب الاسtigmatism compatible or no?
Yes, for me.
Yes. How much is there in the?
2.
هنا كم؟
No.
0.5 وهنا 2.1.
Yes.
متى نقول انها not compatible if it is more than
1.
1؟ اي
Yes.
فهذه اكثر صح؟
Yes.
اي فهي not compatible صح؟ طيب بس انا اتكلم كاماونت. الاكسس 15 بس الاماونت كذا فهي اور كذا واحده منها. طيب وش بعد عنده؟ في اشياء زياده suspicious. بس البوستيرير انت بتمشين على الثينست صح؟ فهنا الثينست على الدائره هذه. بس انك you will be suspicious about this one. Yes, agree. طيب لانها قريبه بعد معناها من 12 على طول 18 يعني زادت مره. أنا for me usually I compare both eyes even for the posterior elevation. If one is 17 and the other one is 8 يعني في big discrepancy between both eyes. So أنا صراحة أبدأ أوقف هنا مع أنها ما هي مكتوبة في هذه الأشياء في البحوث وكذا بس إنه ليه في big difference. طيب يلا
Y coordinate
Y coordinate.
9.5.
طيب فهذه البلن. You will go for surgery or no?
No.
Why no? Patient insisting.
I will
يبغى يروح عسكرية.
يروح دكتور ثاني. I will follow the patient. I will not proceed.
يقول لك تقديمي بعد شهرين. ترى هذا الريل سيناريو. عمره 18 19 وجايك يبغى عسكرية وهذه عينه.
I will not go for surgery.
ليه؟ بيقول لك ليه يا دكتور؟ بيقول هذه ما هي حمراء.
The signs of the Pentacam are suggestive of keratoconus. It's not.
والأذر آي. أي فلازم تقول الأذر آي. عرفت؟ فخلاص انتهى الموضوع. أصلا هو نط 2020 حتى بالأذر آي. فهمت علي؟ فهذه الفكرة منها. فلما تيجي هنا تلقى كل شيء أحمر. عرفت؟ هم دائما في الاختبار بيجيبون لك هذه ويخلونك تعلق عليها تقول الاذر اي بينتظرون شوي يخلونك تطلع من هنا تطلع من هنا لما بعدين هم يعطونك الاذر اي بيقولون ما قلتها من البدايه قبل ما تبدا قل ابغى اشوف العينين وابغى اشوف الريفراكشن حق المريض قبل ما تبدا البنتكام. طيب بغض النظر وش الدياجنوس بغض النظر عن اي شيء ريفراكشن بوث ايز. طيب هذا الاكزامبل بوست دالك ولو سوتشر. أحد ثاني يلا.
Okay, to describe?
لا هذه اللو سوتشر this is Pentacam.
Okay, so the patient has
presented to ER.
okay, so the patient has 11.8 diopters of astigmatism.
Do you think it's high?
Definitely.
Yeah, okay.
But the suture has nothing to do with it's not inducing, I mean, this astigmatism. It's on 9 o'clock, right?
9 o'clock, okay.
Yeah.
So it is loose, ها? إذا صارت loose وش بيصير الديستريبيوشن؟
If it is loose, it should elevate. I mean, it should.
طيب this is elevated. How can you know if it is elevated or no by Pentacam? كيف تعرفين بالبنتكام؟
No, but I mean it's flat on the.
لا كيف تعرفين انها elevated بالبنتكام؟
The elevation.
Elevation. Is it elevated here?
It is elevated.
It is elevated. طيب وش بعد؟
I mean on the same axis it's flat.
Here. Okay. The steep suture. يبغاك تجاوبي.
Tight suture. Steepening.
Steepening. طيب هذه لوز.
Flattening.
وين بيصير الستيبنينج؟ في الأماكن الثانية.
Yes, 90 degrees away.
ما هو بشرط على حسب عاد وين صارت الأقوى سوتشر ماسك الموضوع. طيب فهنا صار أقوى سوتشر هنا. طيب مسكت الموضوع هذا. والحين 11. طيب وجايك في الإي آر. بتسوي له بنته كامل هذا اللوز سوتشر ولا بتقولي له أطلع بس؟ بتشيلين السوتشر بتطلعينه.
Well, how long ago was the surgery?
5 شهور أو 6 شهور. كاتبها.
Well, is there a gap or gapping or no?
في elevation الجرافت elevated.
So resuture.
اي حتى لو ما في elevation هنا وفيه very significant astigmatism طيب عادي you can resuture it. طيب فهنا you will resuture. طيب فافتر resuturing صارت 4. هذه يوم سويت لها الريسوتشرنج كنت انا متعمد اني اخليها اوفر تايت. ليه؟ لانك اذا جيت تسويها سوتشرنج بعد فتره بتصير اقل شوي، عرفتي؟ فترجع بعد فتره الاربعه ممكن يصير 2-1 كذا، عرفتي؟ فدخلتها سويت لها ريسوتشرنج بس. فهمتي علي؟ فمن 11 يصير 4 بالعكس الاتجاه، بعدين يرجع يصير 2-1 كذا، وخلاص ويستمر عاد لما بعدين يجي وقت شيل السوتشر. طيب this is do you want to continue on?
Yes, do 2 more before. Yeah.
طيب أحد ثاني.
R3. Who's R3?
طيب هذا بوست ECCE or corneal ECCE. طيب 3 months ago for the right eye.
Okay.
فsuture still in place.
Yeah.
Will not lose.
So 7 diopter astigmatism with the rule. 3 months ago. It's considered to be. What's your question? Should I remove the sutures?
Yeah, what you will do? Type of astigmatism with the rule you answered.
Yeah.
So بتشيلين suture ولا لا؟
How much is the vision uncorrected?
20/100.
Yes, theoretically it can be removed after 3 months of the surgery, and 7 is considered to be a significant astigmatism. Yes.
طيب اوكي. طيب خلي اعطيك اخر اكزامبل. هذا
First visit.
Describe.
Okay. So first, to start with, the fixation is not as good. Q value is.
Why it's not good? Do you think?
It's yellow.
Yeah. Why? Why do you think it's not good?
He's not concentrating.
Yeah, but maybe uncooperative patient or pupil is dilated.
I see.
There's a clue.
Okay.
pupil كيف كبير.
And pupil is not round as well.
So fixations يعني ما هو regular يعني بعد شوية أوريك وش الحالة. أبي أوريك regular pupil بس هنا ما هو regular، معناها إنه كانت تتحرك patient. طيب اقرأيها يلا اقرأيها كأنك في اختبار.
Okay. So he has K2 is steep, 51 more than 47, so it is.
طيب خليني أخليك تصيرين منظمة أكثر. قولي أول شيء بشوف الاسم، العمر، العين، متى تسوى. Look for both eyes and refraction. Then I will start with the QS, then Q value. Okay. بعدين روحي ل K1, K2. Okay. يلا كملي.
You want to show me the other eye from now or?
لا ماني موريك إياها أبد.
Okay, so K2 is high, 51. He has 6 diopter of withdrawal astigmatism. Did he have any previous surgery, anything? This patient?
No.
Okay.
First visit.
Okay.
Came for cataract surgery.
Okay. Then the thickness map. Okay, so first the axial, the axial map, 50 and 40. So he has a symmetric bow tie in terms of shape of astigmatism.
طيب خلينا ننزل هنا. خلينا ننزل هنا. طيب دقيقة خلينا ننزل هنا ونخلصها بعدين نطلع هنا. طيب هذولي. Thinnest location
507. cons-
والكي ماكس. هذه علق عليها عبد الله وخلصناها. اوكي طيب كيف تعلقين عليها؟
K max. There's significance between K2 and K max.
اوكي
So this is abnormal. It is centered, and the y-axis is decentered, or what would you call it?
عادي 0.25 وبالبلس ما هو بالماينس، لأن المريضة كانت تشوف فوق دايريتد وانكوبرتيف كل شيء. طيب خلينا الحين نروح لهذه. How to comment regardless of this case. How to comment على الأكزيال map. What
So
you will say. The values.
Yes, the shape of
The shape. Excellent.
the superior inferior disparity
Excellent.
and
Skewing.
skewing.
طيب والسكيوينج كم الانجل حقته وكم لازم الفاليو عشان نقول انه بوزيتيف سكيوينج او significant skewing؟ 21 والفاليو الاستجماتيزم فاليو
more than one diopter. 1.5.
اي 1.5. طيب اوكي ف this is regard so it is the steep cornea. Okay and here
So the location of the thinnest location. And the y-axis,
okay
and the comparison between this eye and the other eye.
excellent.
Difference of 30, and the fourth point. The value of the thinnest location.
اوكي طيب ولما نجي على الماب هنا you have to compare inferior superior disparity صح؟
Yes.
طيب ولازم تعلقين على الشيب. فهنا زي اللي فوق الايلاند اوف ثينينج صح؟
Yes.
طيب فالفوكال is it correspond to the elevation or no؟
Looks, yeah. Looks.
هذا من اهم الاشياء اللي تعلقين عليها انك تقولين corresponding or no. فcorresponding صح؟ هنا. طيب فعندنا steep cornea وعندنا significant elevation, posterior elevation, tongue-like, central, with corresponding area of thinning, focal thinning. كيف؟ و there is difference. بس still ما بعد صار لها skewing. لو تشوفينها بتقولين ممكن انها كيراتوكونس صح؟ صح؟ بس ما راح تقولين انها كيراتوكونس، بتقولين ابغى better quality اول شيء. ما تقدرين you cannot label the patient as keratoconus unless you have good quality Pentacam. But what is your differential diagnosis of this?
So keratoconus, post LASIK ectasia if he has done any.
Okay.
Pellucid, not sure.
لا pellucid غالبا ما راح تصير زي كذا. سكار.
He has.
ليه السكار ممكن يسبب؟ وش ممكن يسبب السكار؟
Central flattening.
على حسب وين مكانه. هو يسوي فلاتنينج في مكانه وستيبنينج في مكان ثاني. بعض الأحيان لا. بعض الأحيان لا ترى. مو هو بدايم بس الغالب 99% إنه صح بس بعض الأحيان لا. أذكر فيصل مكان معي مرة ووريته سكار ومسوي ستيبنينج ما هو فلاتنينج. قلت له شوف فيه ستيبنينج واضح في الكورنيا ومسوي ستيبنينج فعلى حسب يس بس انه فوش الديفرنشيال برضو زياده. طبعا ليه اذا في سكار ممكن يسبب لك كل هذه اللخبطه؟ لانه توموغرافي فيري سنسيتيف تو سكار. طيب فهذه الكورنيا كلها سكار. طيب وفيه posterior keratoconus. طيب ف one of the differential diagnosis is posterior keratoconus ولكن السكار can give you any picture. Can you give you like keratoconus? If you see it you will say this is keratoconus but if you examine the patient you will see corneal scar. طيب يعطيكم العافية. شكرا. دقيقة 4 هذه هذه كنت انا مغير الماشين، قلت ابغى اشوف كم اي انديوست، فرحت غيرتها ورجعتها. انا رحت غيرتها، قلت بشوف كم تطلع لي بالاذر اكسس.
والبوستيريور
شلون البوستير؟
خليت البوستيريور.
البوستير ما يهمني كان، لانه خلاص دالك كان.
شوف الحاله اللي بعدها، واحده مخليها بالماينس هذه بالماينس مخليها،
أي.
هذه احنا ما نشوف ساينس فيها.
شلون؟
العاده ما نشوف ما نشوف ساين
الا تصير بالماينس.
اي احنا ما نشوف، عاده نطلبها بدون
لا تقدر تغيرها كذا.
ايش البوينت؟ ليش غيرت خليتها ماينس؟
أنا